Okay. Thank you. Good evening. And now I can unmute.
Yeah, you're audible now.
Yeah.
Manas, how are you?
Fine. Could you manage to get the visa or
Hi, how are you? Did you start recording?
so we have 4 minutes to go? You could check your this thing slides, Anand. Can you share and check it's working or not?
Sure. Should be able to see my slides now.
Yeah. Can you change? Check. Just change the slide. Yeah. Request Dr. Albert, can you please check it?
I'll stop sharing.
Albert is not there. Dr. Linda is there. Yeah, can you please check whether Can you please share your slides?
Sure. Should be okay.
Yeah, just check. Go to the next slide. Dr. Dattatraya is there. Okay, Dr. Albert has come back. But Albert, can you please share your slide? We'll check it's working or not. Dr. Albert, can you please share your slide?
Где? Окей, на презентацию показать. Нет. Окей?
Yeah, yes.
Окей? Окей.
Yeah, that's fine. Is Dr. Dattatraya there? Yeah, can you please log in? I just want to check, share your slide and check it's working. Yeah, just unmute yourself, just share your slide.
Dear friends, I think
So please
we can start. Abujar is with us, Manas is with us.
Okay.
Actually,
so we start.
This is our 7th and 8th symposia, online symposia. We will start with, and I will give the moderatorship to Abujar and Manas.
Okay. Thank you, Dr. Prasanna, for agreeing to organize something on Glioma. There has been a lot of changes in the strategies of management of Glioma, and histopathology has actually changed the way we treat the patients. Before we start, Dr. Anand speaks on how biopsy histology has changed the way we look at tumors. I request Dr. Abuza to get a few comments on the topic.
Hi everyone. Today it is an honor to moderate this session with the Professor Manas. Today we will talk about to advance in the management of gliomas with the expert. Firstly, Professor Anand will start. I think you can share your presentation and we can start the session.
Yeah, Dr. Anand,
Thank you. Yeah, thank you. I am sharing. If you can see my slides.
Yes.
Yeah. Thank you so much. I grateful to the WFNS Education Committee, Dr. Zalili and Dr. Manas, for providing me with this opportunity. The talk is under the heading of Advances in Management of Gliomas. And my topic is, has pathologic classification changed? So the first disclaimer, I'm not a pathologist, I'm a neurosurgeon. but with a bit interest in neuro-oncology and most of my knowledge in this field, I thank my teacher, mentor, and colleague, Dr. Vani Santosh, from whom I have learned a lot, and I have borrowed a lot of slide material and information to share with you all. So at the outset, again, has pathologic classification changed? The answer is simply yes. Why does it keep changing? Because we do need accurate classification. That is the need of the hour because of clinical management of individual patients. They keep differing. We all have seen a lot of GBMs do very well in spite of the worst prognosis, and some of the good, great so-called tumors do badly in spite of us expecting them to do well. So we need more accurate classification. We need uniformity in clinical trials for experimental studies, population-based data, and support from external agencies, so on and so forth. So the classification initially was the old one. Then there has been multiple editions that have happened since 1926. Till 2007, there was grossly not much of a change. Then there has been an explosion of molecular data with IDH discovery. And then the 2016 classification was considered a major breakthrough. But from 2016 to 2021, there has been a real explosion, further explosion due to multiple C-Impact Now publications, that is the consortium to inform molecular and practical approaches to CNS taxonomy, not official WHO. There were 7 publications which has revolutionized the way we look at and classify these tumors. And now it has led to the hybrid taxonomy. So what are the changes that we are looking in these tumors classification? So if you see, is it just a facelift change or are there deep changes within the tumor grading? Yes, there is a revision of the taxonomy. There is a revision in the way we grade these tumors. It is not just based on histomorphology. There is restructuring of tumor groups, and there are new tumor types and subtypes. Then the terms not otherwise specified and not elsewhere classified have come in with more meaning, and a layered integrated reporting is being encouraged. The Arabic numerals that we know of 1, 2, and 3 has got replaced to reduce transcription errors, and the CNS WHO grade is introduced to identify it with CNS. So you would see like this, you have a tumor, and then it says CNS WHO grade in the numerals 2, 3, or 4. Now, about NOS and NEC, this may be quite confusing for the neurosurgeons. When we have not done certain tests to further characterize the tumor as advised by the WHO, then we have to put our diagnosis as per histomorphology and add the letters not otherwise specified next to it, because we have not specified it further with further tests that are needed. But once you have worked out all the tests and you don't find it fitting in to any of the current WHO diagnosis, then it becomes not elsewhere classified. I'll elaborate on this further as we go in this talk further. Final one is the layered classification. So the site comes first and then the identifier. So like this cerebrum, and then the identifier, what is the diagnosis? The integrated histomorphology and molecular diagnosis comes first. So it's say a supratentorial ependymoma. It says NOS, that means further classification has not been done by further markers suggested by the WHO. Then the histopathological classification is enumerated. Then the CNS grade is enumerated. And then the molecular information, what has been done or not done, is summarized. So this way, it's a more elaborate descriptive diagnosis rather than just giving a singular diagnosis, which is more informative. The last is that they have also specified essential criteria and desirable criteria. So essential criteria are definite must-have features, and desirable criteria can be supportive but not mandatory. So we need not exhaust the patient's bank to get a diagnosis. If we have the essential criteria satisfied, it's enough. So we come down straight to the classification. So this is the broad classification of WHO 2021. The glioneural tumors are here. So as you can see here, these are the types. Rest we are not going to concentrate today. And even in these types, I'm just comparing it to the WHO 2016. You see, this was the glial glioneuronal tumors and the astrocytic tumors. But now they are classified into major 4 types. That is the adult type diffuse gliomas, the pediatric type diffuse high-grade gliomas, pediatric type diffuse low-grade gliomas, and circumscribed astrocytic gliomas. So we are again not going to deal with the pediatric and circumscribed gliomas today. We are straight going into the adult type diffuse gliomas. So if you actually see the first time, the gliomas as classified as adult type or pediatric type. This is the major difference in the new classification. Now further, if you compare between 2007 to 16, 2007 looked very simple. It was just diffuse astrocytoma, anaplastic astrocytoma, glioblastoma. Anaplastic and malignant were being used frequently, and oligoastrocytoma was existent, gliomatosis cerebri was existent. In 2016, the IDH mutant type or IDH wild type came as a suffix to the main ones that were described in 2007. And the term of oligoastrocytoma was still present, and gliomatosis cerebri had been deleted even in 2016. Now, if you look at in 2021, it has been grossly simplified. The adult type diffuse gliomas only 3 types. They are either a IDH mutant astrocytoma or a oligodendroglioma, which is IDH mutant 1p19q co-deleted. And the IDH wild type is a glioblastoma. So these are the only 3 entities that the adult type diffuse glioma is existent as of 2021. That says a lot about the understanding. Now, how do we go down to break this down? Again, I'm showing you the old classification, which had astrocytoma, oligoastrocytoma, oligodendroglioma, and glioblastoma. It was further divided into IDH mutant or wild type, and then further classified as whether it is diffuse astrocytoma, oligo, or glioblastoma type. But what is it now? It is the oligoastrocytoma has gone completely. We are overarchingly seeing the IDH type. So it is either IDH mutant or IDH wild type. If it is IDH mutant, we do a ATRX loss and T53 mutation. This is characteristic of a diffused astrocytoma IDH mutant. The other side is the absence of these two. There is ATRX is retained or T53 is not mutated, and they are characterized by 1p19q co-deletion. This is diagnostic of oligodendroglioma. And this stream has only grade 2 and 3. The astrocytoma has grade 2, 3, and 4. The Roman numerals are replaced by normal 2, 3, and 4 numbers. There is no more a secondary glioblastoma. That means you don't call a IDH mutant glioblastoma. They are IDH mutant grade 4 gliomas. All glioblastomas are IDH wild type. There is no more IDH wild type grade 2 or grade 3. We'll see them shortly. Now we'll go into each of these 3 types. So this is the astrocytoma IDH mutant. So what is the essential criteria? It should look like a diffuse infiltrating glioma on histomorphology. IDH mutation should be positive. There is a loss of nuclear ATRX expression or ATRX mutation and or exclusion of 1p19q co-deletion. The desirable factor is the T53 and methylation profiling or astrocytic differentiation by morphology. So this shows, the slide shows the IDH mutation, the ATRX loss, and the P53 mutation, and this is retained. That is CDK and 2A. This is for grading, and this does not apply for the diagnostic criteria. If by these you diagnose it as an IDH mutant astrocytoma, and you have a grade 4 morphology like necrosis or mitotic activity with microvascular proliferation, straight away it is grade 4 astrocytoma. However, if there is only grade 2 or 3 by histomorphology, then a CDK and 2A needs to be done by a FISH approach to know whether they are aggressive behavior or not. that will straight away take it to grade 4. So in summary, for astrocytoma IDH mutant, you have 3 grades. This IDH mutant glioblastoma is not there anymore. It's called IDH mutant grade 4 glioma, which could be histologically defined, or it could be defined with FISH of CDKN2A. Now, this is the way the grade goes. If it is well differentiated, no anaplasia, no mitosis, no microvascular proliferation, it is grade 2. Same with it, grade 3, if it is only mitosis is present, then you need to do a CDKN 2AB homozygous deletion to confirm they are still grade 2 and grade 3 and not going to have a aggressive behavior. So this is the secret for those tumors which look benign, grade 2 or grade 3, but who tend to perform badly when you follow them up. They may be CDKN2A positive. It's about in 20% of cases. But if directly in histologically they are having frank features of grade 4, it's only or. You need not do CDKN2A in all the patients. It's either or. So once you find these histologically, they are straight away CNS WHO grade 4 astrocytoma IDH mutant. So that is summary of this. 3 grades, 2, 3, and 4. If mitotic activity is 3, microvascular proliferation necrosis is 4. No change till here. If it looks like 2 or 3, you are in doubt. You have to do a CDKN2A for co-deletion to grade it to grade 4. If you are not able to do this, then you have to add the NOS next to it. So it is ATRX loss, P53 mutant, which are diagnostic essential criteria. Don't forget the T2 flare mismatch. I won't cover it here for lack of time. Prognostic factors remain age and extent of resection. That is not changed. Just giving you an example of a lady here with a insular glioma with a residue left because it could not be resected because of speech disturbance. She had ATRX loss, 1P19Q not co-deleted, grade 2 histology. So we didn't know whether to observe this or treat it directly with RT. To do that, we did a roll of CDKN2A. If this was retained, so we could continue observing this patient than giving upfront treatment because we know they are unlikely to progress like a grade 4. Another example of this patient who had a diffuse astrocytoma with endothelial vascular proliferation, mitosis frequent. So this is directly grade 4 because of histomorphology. But see here, the pathologist has reported IDH positive. So this becomes IDH mutant grade 4. However, they have asked for a CDKN2A mutation. This is superfluous and not essential. So I think I was able to bring out that difference. Now in oligodendroglioma, this is IDH mutant, 1P19Q co-deleted. So you have a glioma. Here the ATRX is retained, P53 is not mutated, and FISH shows 1P19Q co-deleted. This has become a diagnostic marker. So this diagnostic marker is essential 1P19Q co-deletion, and it is inversely related to nuclear expression of ATRX, which you can confirm with also a third promoter mutation. So in cost constrained circumstance, or where FISH is not available, one could go ahead with ATRX under third mutation to confirm whether it is an oligodendroglioma. However, in WHO, this is essential criteria to diagnose oligodendroglioma. So for oligos, there are only 2 grades. There is no grade differentiation with any marker. Diagnostic marker 1P19Q. ATRX could be used as a useful mutually exclusion tool. And the prognostic factors remain age and extent of resection, even in these tumors. Now coming to the third group, that is the wild type. So the IDH wild type, practically all of them are glioblastomas. There is no IDH wild type grade 2 or 3 in this nomenclature. But if microvascular proliferation necrosis is not there like the old classification, we have 3 additional markers: the EGFR amplification, third promoter mutation, and +7 -10 chromosome copy number changes. If these are present, in spite of the tumor lacking histology of grade 4, the tumor is glioblastoma. That is IDH wild type CNS grade 4 tumor. If all these are negative, then it's a different tumor. It may not be an adult type diffuse glioma. It could be a pediatric type glioma. One has to go for IDH sequencing, confirm it is still IDH negative, and then go for histone mutation. I'll cover that shortly in the next few slides. So IDH wild type is grade 4, grade 2 or 3 doesn't exist. Histological criteria is enough. You need not do these if microvascular proliferate necrosis are obvious. If it looks like a grade 2 or 3 IDH wild type tumor in spite of sequencing, one has to do one of these three. Either of them is positive, it confirms a GBM. If you're not able to do them, you can report it as IDH wild type NOS, GBM NOS. Give you a quick example clinical scenario here, a biopsy done for a deep-seated lesion. You can see that here there is no necrosis or microvascular proliferation. Patient was IDH negative. So pathologist asked for sequencing and 1p19q co-deletion. This is questionable. Sequencing is the right way to go. And sequencing findings showed that it is wild type status. And they asked for MGMT methylation, which is correct. But the final diagnosis, they have suggested both TERT and CDK in 2A. This is applicable only for IDH mutant gliomas. Here it has no role. TERT is correct. You could have asked for TERT, EGFR, and +7 -10 if they are available. And if they were positive, then it confirms that it is grade 4 because histologically it is looking like grade 2 or 3. Now we are coming to two other groups. This is the midline glioma. We would have called this DIPG. DIPG term does not exist anymore. It's old term. These are diffuse midline gliomas, H3K27 mutant, histone mutant. This study has to be done, can be done IHC. This alteration is very poor prognosis and IDH has no implication in these tumors. If the tumor is diffuse like this, as you can see, one side involving crossing the midline, involving septum, it is old terminology of gliomatosis cerebri. Nowadays, it's called as diffuse hemispheric glioma. This is the pediatric type high-grade glioma, which H3G34 mutant positive. They have a poor prognosis. If it is negative, again, it goes as not elsewhere classified. If it is not doable, then you have to report it as NOS. Again, IDH has no role. So in short, we can say that the grading has changed. It's Arabic, not Roman numerals anymore. It is in the grades are within subgroups. The terms NOS not otherwise specified if tests are not done or not elsewhere classified. Tests are done but do not fit into any particular category. And the prognostic has become more uniform as the members are more uniform in a group. So this table quickly summarizes the changes. I would not go through them again, it's just a repetition. Just to confirm to the audience, what are the tests that are finally needed to get a proper diagnosis in the new classification? You just need IDH and ATRX-P53 with a MIB count if possible, though MIB is not a criteria. So IDH is easily done by IHC. You can ask for a sequence if it is negative. And ATRX-P53 can be done by IHC. And if FISH is available, 1p19q will give diagnosis for a oligo, and this will give for a grading CTK in 2A or B. The rest can be easily done with IHC. So most of the classification can be done with IHC. So you can see here, this is a mutant glioma. So mutant glioma, if it is morphology is already microvascular proliferation necrosis, straight away grade 4. This is for FISH. If it is positive, it is oligodendroglioma. If it is looking like grade 2 or 3, you do CTK in 2A and it becomes negative. It goes for grade 2 or 3, IDH mutant glioma. If it is positive, it becomes grade 4, even if it looks like grade 2 or 3. Now, this is the group where sequencing is being done. If the IDH is negative, it is IDH wild type astrocytoma. If the sequencing is positive, it goes down the oligo way. Here, if the sequencing is positive, it goes down the astrocytoma way. So we forget these two. These were in the older slide. If it is negative, what do you do? If IDH sequencing is negative, then you do the EGF, and it looks like grade 2 or 3. These three for grading has to be done, EGFR TERT plus 7 minus 10. If they are positive, it becomes glioblastoma wild type. If they are negative, they don't become grade 2 or 3 IDH wild type astrocytoma. It is not elsewhere classified. You're supposed to do the histone mutations here, as I said, to look whether it has a pediatric type diffuse high-grade glioma. And if it is present, then it becomes a pediatric type diffuse hemispheric glioma. One small caveat here, in an elderly patient, you rarely get IDH positive tumors. So if the age is high and the patient is immunohistochemistry-wise negative for IDH, one need not insist on sequencing. You can directly take it as glioblastoma IDH wild type. In a younger patient, you would look for a sequencing. And in midline tumors and hemispheric tumors, irrespective of age or grade, please get the histone mutation done. The MGMT need not be done in all patients. It's useful only in elderly patients and in recurrent settings for prognostic or predictive marker. So finally, summarizing, diagnosis grading is still uses a lot of histomorphology. The mitosis, microvascular proliferation, necrosis is still important. Molecular genetics, IDH is diagnostic. ATRXP53 diagnostic for astro, 1P19Q diagnostic for oligo. Grading, if it doesn't look like a grade 4 directly, if it is grade 2 or 3, it may get bumped up to grade 4 if CDKN2A is positive in astrocytoma. If TERT EGFR plus 7 minus 10 is positive, it may get the glioblastoma. And MGMT is only in elderly GBMs. With this, I'll conclude my presentation, and I'm open to any questions now or at the end as the moderators feel. Thank you so much for your attention.
Thank you, Dr. Anand, for an elaborate view on the histology and how to interpret it. As we have overshot time, we'll have the questions at the end. And I'll request Professor Albert, Chairman, Department of Neurosurgery at Russia, to speak on the recent advances in surgery for glioma.
Okay, possible? Possible, yeah?
Yes, Professor Albert, you can share your screen. Yes, we can see.
Okay, thank you. Good day for everybody. Thank you very much for invitation my team to share our experience about the glioma surgery. And today I want to speak about the glioma surgery with using ICT hybrid operation room experience. I am from Tyumen city, it's from the Russia, just midpoint of the Siberia of the Russia, and I present the team of the Federal Center of Neurosurgery, and we have now 15 years of experience and more than 70 cases totally, and near the 5,000 elective cases per year. So now again, about our equipment for this kind of surgery, because glioma surgery is not so easy, not so simple at first, and so why just to make some adventures, we introduce some new technology. So why one of the first is the hybrid ICT operation room. You see the CT by the rails go during the surgery. It's possible to in any stage, if you have some question during the surgery, make the CT and the CT with automatic registration possibility also. Actually, okay, another very important new tools for this kind of surgery is 3D exoscope. Why is 3D exoscope? Because during the surgery, the glioma tissue is not well differentiated from the normal tissue. So why color differentiation, white different, black differentiation? It's very important just to distinguish the border between normal tissue and the pathologic tissue, and also 3D depths of the visual give us more additional safety and other good possibility for this kind of surgeries also. So 3D exoscope now one of the main advantages in glioma surgery also. Not only exoscope personally, also we combine end and exoscopic surgery both together. So some, if necessary, just to see some remnants around the corner, for example, we use also combination of the exoscope. You see on this slide, exoscope and the exoscope. And it is very safely now compared to the microscope, just to introduce endoscope in the depth wound without any with big safety. So the problem in glioma surgery, one of the most problems of glioma surgery is not achieving total tumor resection. So why we have a lot of possibilities, ultrasound, 5-ALA, ICT, neuronavigation, fluorescein, and so many methods just to improve this total tumor resection. But in our idea is that not only one technology is possible just to have good results. So combination of these methods together, for example, ICT, ultrasound, neuronavigation, and so on, give us more possibilities for this challenge type of surgery. Why ICT perfusion? Because we know what two of the most important factors in determining the malignancy of the gliomas is the ability of the infiltrate the brain parenchyma, and the second one very important is the recruit or synthesize vascular networks for the further growth, neuroangiogenesis. So CT perfusion, especially in high-grade gliomas, can be give us more possibilities to total removing of this tumor. Computed tomography perfusion, CTP imaging. Perfusion imaging using CT can provide additional information about tumor vascularity and angiogenesis for characterizing the glioma. The CTP provides a linear relationship between tissue attenuation and tissue concentration of a contrast agent, unlike perfusion of MRI imaging. And hence probably provides a more robust and less biased estimation of the hemodynamic tumor blood volume and physiologic tumor vascular likeness parameters. So, why the intraoperative CT perfusion compares the MRI give us better possibility just to visualize CT in the glioma, and not only glioma, and the most important is the remnants of the glioma. You see on the slide, and you see the CT perfusion, and you see the remnants. Just we see and when removed after this visualization. So why CT brain perfusion have big advantages now? It's very fast, available, suitable for the invasive care patients, affordable, safe with different implants, high spatial resolution, robust quantification, CBV and permeability can be measured with the same study and automatic registration in CT. But also have some disadvantages. Small lesions may be missed, limited visualization of the posterior fossa, complication associated with the contrast administration and radiation dose. But current CT machines, current CT device just diminished all these disadvantages. So not only our view for this kind of surgery, and also some people in the world also have experience with the ICT perfusion and have also same view. Surgical resection using ICT may improve the outcomes of the patients with the lower grade glioma. For example, our Japanese colleagues present his results, and you see the if make surgery without ICT group, don't see the remnant. If use ICT group, so a lot of remnants see, and additional resection needed. Also, very important tools for this kind of surgery. We combine it with ICT's interpretive ultrasound in glioma surgery. So one of the most important is the correction for the brain shift, and the remnant visualization. And you see on the slide how it's possible during the operation room. This is our CT and ultrasound probe navigated for this kind of surgery, and you see the full screen about this procedure. Another one of the most important for this kind of technology is interpretive ultrasound is very important for the vascular landmarks recognized. And you see on this short video, how it's possible to visualize main vessels inside of the tumor. So this possibility can give us more safety during the surgery. And another one of the most important tools is the automatic registration. And you see in our operation room, we have very special CT with possibility of the automatic registration. Okay. And at the end, this is our special operation room just for glioma surgery. And you see there's a lot of equipment inside. For example, exoscope, ICT, 3D screens, ultrasound, navigation, and neuromonitoring, interpretive neuromonitoring. You see the special suction device with navigated suction device with neuromonitoring possibility from the tip. Do you see the ultrasound, navigated ultrasound also? And you see the special 3D screen from the exoscope. And this is ICT. So how we use our technology with CT? So we have low-grade gliomas, so native CT and interpretive ultrasound is sometimes it's enough for complete tumor removal. If we have high-grade glioma, so ICT perfusion is a very important step. It's very important in one of the main steps for this kind of surgery, and additionally with interpretive ultrasound. But again, CT perfusion is most important to see the remnants. So this is now our cases about this presentation. What I said before, I want to present some patient, male, 46 years, with high-grade glioma. This is MRI perfusion, is MRI before, and this is our surgery. So at first, ultrasound navigation we use just to recognize tumors through the dura, and you see the ultrasound picture. You see the tumor very well, and you see the lateral ventricle, third ventricle, and so on. After recognize the tumor, just we open the dura. And you see the main vascular landmarks, what we recognized before by ultrasound, for example, big vein. And one of the most important step is just to save this big venous pathway. We open the arachnoid, devascularize the tumor by cutting the vessels after coagulation. And when we start debulking of the tumor, and piece by piece we remove tumor in this way. And during this kind of surgery, we use, you see, the special suction device, what give us possibility of the interpretive neuromonitoring possibility. So we, during the suction of the tumor, we know where is the main important tracts. Also, we use ultrasound, also with possibility of interpretive neuromonitoring. You see that from Sanoka company. So this combination gives a big safety for the function of the patient, for the safe function of the patient, motor function. And we achieve gross total resection. You see our interpretive CT perfusion, and you see the total removing without any remnants. This is the control of our interpretive ultrasound possibility. This is the morphology, glioblastoma, grade 4. Another case, it's a low-grade glioma. It's a female, 53 years, and you see the MRI before, just near the precentral gyrus with motor functions. So it's very risky for the loss of the motor function of patient after surgery. So why we use our ICT possibilities. And you see MRI with contrast, but no good body. This is perfusion before operation, and this is our planning of the surgery before. It's 3D model with corticospinal tracts, and you see the corticospinal is just behind the tumor, and you see the main vessels around the tumors. This is our operation plan, just for removing. Just we recognize before the plan main landmarks, like gyrus, tracts, volume of the tumor, vessels landmarks, and so on. And mainly we create this our knowledge for the 3D models. This is patient position. This is special equipment. You see the special frame. This frame used with ICT, with no metal. Special Dora frame. This is carbon, from carbon. And again, first step, we open the dura mater. This is superior sagittal sinus here. Sometimes use a special knife. It's very useful if brain have some edema, just to prevent injury of the brain during the open the dura. Second step, we recognize main landmarks, especially vascular landmarks, and especially vein. Again, we will see before the surgery special model, the precentral gyrus, corticospinal tracts, and now we see the operation field. This is a tumor. This is drainage veins, most important drainage vein. It's completely correlate with our 3D models. This is very important for the surgeon. Just understand before the surgery in 3D. Then we start the surgery. Just open intercommissural fissure. We dissect all veins, you see, just to save these veins, drainage. Now, next step is very important, the monitor mapping of the main functions. And we just recognize the precentral gyrus, very correct, by the mapping. Just to try to recognize the function, motor functions. Step by step. Now we use the ultrasound, also interpretive ultrasound, navigated ultrasound. just to additionally recognize the body of this kind of tumor. And then start to remove the tumor. First one, open the arachnoid. And the most important step is we must to preserve the main venous drainage. You see, like this one. And start to remove. And in this step, we use, you see, special ultrasound, special suction device with the possibility of the interpretive neuromonitoring, because it's a very dangerous place, and corticospinal tract is very close. And step by step, we again save the main venous drainage. You see, like this. Constant intraoperative monitoring by the suction. Constant. It gives us possibility for the gross total resection. Again, Sanoka also we use. Sanoka also have the function possibility for the monitoring, interpretive monitoring. So you see. This is our result, gross total resection. This is the size. This is the morphology, astrocytoma, grade 2. Another good possibility, and sometimes we combine it also in glioma surgery, is a laser technology. It's possible to use additionally for this gross total resection also photodynamic therapy. We have some drugs like a photolone, for example, and it's possible to irradiate. And this is the morphology you see before irradiation. This is after destruct additionally the tumor cells, and also give more survival rate for the patient. That's how I do it. So after I remove gross total, remove the tumor, I additionally use the laser on the cavity, into the cavity of the tumor. And you see, this is the dose, time, and so on. Powerful of the laser. So also very good option. Also a very good option for this kind of surgery. Additionally, another one of the most important step to improve our result in glioma surgery, I mean the education in glioma surgery must improve the outcome. So first one is neuroanatomy. White matter dissection is one of the important tools. We must improve microsurgical technique, and we must have a simulating training for glioma surgery also. Education for glioma surgery also very important, like technology. So we have good lab for this kind of surgery. For you see my lab with 3D just for this is the courses about the white matter dissection. This is our courses for the microsurgical training, microsurgical technique improving. See, and this is our simulation training for glioma surgery. And you see, this is a special simulator, 3D simulation, and give a lot of knowledge before surgery for our residents. We have educational activities because the not only glioma but neurosurgery need learning curve. So why we open for the collaboration and welcome for this our educational activity. Thank you very much.
Thank you, Professor Stefanou. This detailed explanation of your technological tools which you used in operating room, also your education method. Thanks for everything. We will accept questions after all lectures, and we will continue with Linda B, and she will talk about the multi-modality tools for glioma resection. Please,
Hello.
Professor. Hello.
Good morning or good evening, depending on which part of the world one's at. And what a pleasure to join this group. It's actually perfect to follow Professor Suyanov's lecture because I think this complements in many ways. Wonderful. So I am privileged to serve a cancer center where I encounter a lot of patients, exactly as discussed this morning, who come in with tumors of gliomas of all varietals. And in my deep view, I think that surgical resection, safe surgical resection, especially for these malignant tumors, should be consistently delivered each and every time, especially because they have to receive chemoradiation very often. And so surgery and the recovery from surgery cannot be a deterrent in the tempo of their course of treatment. With that, how do we do that in a consistent way such that we're not deterred by the perceived risks of surgery, especially for the deeper seated or eloquently located tumors? Of course, I would say that as all of us know, anatomy is the road that we walk on. It is the basis of our foundational knowledge, regardless of all other adjuncts that we have. However, in the individual patient, the map of that road is imaging. And specifically, I want to highlight a couple of anatomic structural imaging that are more broadly accessible. The first is the power of the T2, a true T2 sequence. You can see on the left, this is a two-dimensional T2 MRI slice, and on the right, the same patient in a 3D T2 sequence. Very often, folks think about 3D images as being higher resolution because they're thinner cuts in 1 millimeter. But I would like to point out that you can see the actual structures in far better delineation on this 2D sequence and the 3D sequence, which loses some of the clarity between gray-white differentiation and therefore the actual resolution, despite a thinner cut that might be conferred. Furthermore, there are a number of additional images, whether it's pre-contrast T1 or this white matter null sequence that functional neurosurgeons often enjoy for targeting of thalamic lesions, or the MP2 RAGE flaws protocol. And here you can see the delineation of even structures such as the different regions of the thalamus, the extreme and external capsule in the subinsular region. So all this for me is powerful because it allows us to be able to see more from every MRI that we obtain, even without the additional resources or cost of, for example, tractography and other such things that we increasingly have access to, but not universally. The T2 sequence is perhaps my favorite sequence in thinking about how to better understand glioma patterns, a true T2 and not a T2 flare, because it really allows the differentiation between nodular and infiltrative. And I think edema helps in that. You can see that edema serves as a highlighter in going around almost any important tract here at the internal capsule as a stripe of white or edema surrounding it and be deflected by this subinsular tumor. This is another example of a woman who presented with an intraventricular tumor. And when we study the T2 sequences, we can see these robust Flovoids. So often T2 could be a surrogate for a CTA if one did not have multiple, if patients didn't have the resource to get multiple images. I think a single MRI with a good T2 sequence can serve as both a vascular image as well as a structural image. And also this white matter null really shows the deflection of the internal capsule and the thalamus by this tumor without, a need for additional imaging. And you can see the location of the cortical spinal tracts when we do superimpose that just in the black, as we would expect from anatomy. Furthermore, like this example, this is a patient who presented with auditory hallucinations, and you can see what appears to be an infiltrative tumor, but with 3 different segments. If you look more closely, the difference between this left posterior insular or Sylvian region T2 versus this posterior superior temporal and the underlying subcortical is that the 2 of these are nodular disease and can be safely taken out, whether awake or asleep. The third is infiltrative disease, and that then crosses with important tracts such as language or language tracts as well as function. And the importance of distinguishing nodular disease and infiltrative disease, I think in my mind, is a distinction of being able to take out nodular disease from anywhere within the brain, but infiltrative disease is fraught with potential risk. This is another example of a young man who was sent with initially presumed optic pathway glioma. And the reason for thinking that was because you could see bilateral optic nerves as being very fat. And this rim-enhancing lesion extending into the left proximal optic nerve. These are the right and the left optic nerves. You can see that on the T2, how fat and swollen both optic nerves are. And the question then becomes, is this edema? Is this infiltration? What does this represent? Given the fact that its function was so excellent and better delineation of the actual structural tracts through sequences like this, which you can see depicting his visual tracts right there, we then gain confidence that perhaps that could be surgically resectable. You can see on the postoperative MRI, the normalization of the optic chiasm and bilateral optic tracts and as well as nerves. So this what actually turned out to be a craniopharyngioma and could be peeled from the actual fibers of the optic pathway, as you can see on his postoperative visual fields, which returned to normal. The beauty of a structural MRI, especially the T2 and estimating cortical spinal tracts, I think cannot be overemphasized. Here's a young woman who presented with progressive right-sided weakness, and then you can see this left kind of posterior thalamic lesion, but with a rim of gray, of slightly darker gray, if you look very, very closely at that. And so this is a very unique tumor in that it neither pushes the internal capsule from medial to lateral, as with thalamic tumors, nor from lateral to medial, as with subinsular or insular tumors. And instead, this splits the internal capsule and the cortical spinal tracts, which are depicted in blue here. And the splitting of the internal capsule then becomes even more vivid as we look at the tractography in 3D view. And so here you can see the orange and yellow tracts and really surrounding most of this tumor in all except for a very small swath in the posterior boundary, which then dictates, the pathways, potential pathways of entry into this tumor that splits the internal capsule. And so with that, as suggested, which I'll discuss a little bit more, this to me is really critical for neuromonitoring and for dynamic mapping to be able to take out the tumor. And so the importance of physiology is, if we think that imaging is the real-time map of the unique roads of each individual patient, then physiology is the GPS of that map. It's the live tracking. And so the classic types of intraoperative neuromonitoring includes that of monitoring and mapping. Monitoring, assessing the integrity of the functions, and mapping, which looks for the seeker, the probe of when those important tracks are about to come up. Traditional monitoring modalities include somatosensory evoked potentials, motor evoked potentials, which can cover face, arm, leg. The face, of course, is through the trigeminal SSCPs, as well as the cortical bulbar for facial muscles, which can be important in things that affect the genu in terms of the internal capsule, or for the descending fibers as they go more medially. And then complementary that with the various cranial nerves and bears for integrity of the posterior fossa. Sometimes I frequently hear from individuals that they are hesitant to rely on neuromonitoring because often they will be in the middle of the tumor and the neuromonitoring signals will diminish dramatically, putting surgeons in a quandary of whether to stop or whether to continue. And a number of these changes, we found over the years really are due to brain sag. There are several different patterns that correlate with the change in neurophysiology related to brain sag, and this is one of the most common patterns that we see. You can see from top to bottom, which is a temporal flow of when we have a large tumor, and baseline somatosensory evoked potentials, baseline motor evoked potentials. As resection pursues, sometimes the SSCPs will begin to diminish, followed by a diminishment, especially of the upper extremity and less so of the lower extremity. And as we encountered this pattern more and more, it struck us that perhaps this is because the cavity is collapsing in. The same thing happens when we go through into the ventricles, a loss of CSF. And when the cavity falls in, it's simple physics. The lateral homunculus, has the hand and the upper extremity motor muscles. And so they're more likely to diminish because of poor contact and signals traveling through, while the leg is bolstered by the falx and so more likely to remain stable. Somatosensory evoked potentials are acquired continuously, so every minute or two or so, and so it's more likely to see a drop in that before we see a drop in motors, depending on how frequent the motor evoked potentials are being acquired. And so seeing this pattern change, then it's easy to reverse that physics simply by putting a little bit of fluid into the cavity. And you can see the cavity fill up and the signals go back to normal. And when that happens, then we have confidence that it's a physical deformation or brain sag that causes these signal changes, and we can safely continue resection. So this has helped, at least in our experience, by having a high density coverage of the muscles, because not all muscles are affected equally. And so having some of those muscles go down while others don't can be really useful for being able to realize, detect these changes early. So recognizing and reversing neurophysiologic artifacts in our experience is very powerful to rely and trust neuromonitoring more. I think the use of a technology has to be coupled with maximizing its potentials. Furthermore, it's already been touched upon that image guidance can be very helpful. And what does that mean in real life? For me, the ultrasound is also the single most important tool that we have, because it's the only real-time tool that changes as our resection changes. And more important than the use of the ultrasound, which can be confusing at times depending on the texture of the tumor, is placing of internal fiducials. So for me, the most important thing of using an intraoperative ultrasound is to establish the baseline before tumor resection begins, and specifically to put internal fiducials. And that for me is a small piece of gel foam. More important than placing the gel foam is placing at least 2 to 3 pieces of the gel foam, because 2 dots form a line and 3 dots form triangulation. So those are put around the perceived perimeter, or really any reference that can be easily referred back to. Then one gets a sense of what the boundaries of the tumor are before resection, and can be very, very helpful. So here, this is the placement of a gel foam into a posterior fossa upon tumor specifically. You can see the use of the ultrasound up front to establish that. if using rigid neuronavigation, which I have in every case, but I rarely rely on for interaxial surgery, I do agree that sometimes having the tracker can be very helpful. And here you can see as my hand proceeds during an insert resection, you can see that the tracking move along, as well as the nibbling away of the tumor as in that real-time sequence. So what all of these tools mean, because certainly one can do excellent surgery without any of this and simply based on anatomic knowledge and experience. But just like we had beautiful maps of Boston where I live, 100 years ago, I would say that's no surrogate for us relying on Google Maps to get from the grocery store to my office in the most expeditious way possible. And so to put that all together in a case example, this is a 55-year-old woman who presented with face, arm, leg weakness and brain fog, ultimately leading to evaluation, which shows the classic appearance of an anteriorly originated insular glioblastoma with extension to the orbital frontal and medial temporal regions. And when we look at the T2, we also appreciate that despite the size of the tumor extending throughout the extent of the insula, but it's really sharp, well demarcated, and you can see the grayish tumor and the difference between that versus the surrounding edema from the mass effect. The cortical spinal tract, as we would anticipate, course medially and are deflected downwards along the boundaries of the tumor. And so putting together all the different tools, the first and probably most important tool is having a clear sense of where this tumor arises and where it goes, which is based on study of the preoperative imaging, along with the intraoperative ultrasound, the navigation, the MRI, which are adjuncts and not a surrogate for the previous, which is the mental map, and lastly, the physiologic guidance. So with that, this is the setup that we have for high density coverage when we do larger tumors that affect face, arm, and leg. And so you can see, for me, almost all insert tumors are performed through a trans-sylvian approach, but it really it's wherever the tumor takes us. So here, splitting the sylvian fissure from inside out quickly gets us to the expansile tumor, and that allows for ease of visualization, as you can see, of the tumor coming close to the surface because of its size, placing of the internal fiducials, 2, 3, or as many as necessary, which you can see with the gel foam right there, the super bright white, the beginning of the tumor, the continuation of the sweep, and the second gel foam right there. So you can envision placing as many gel foams as you want, superior, inferior, anterior, posterior, or even in the depth. And those really allow demarcating the extent of resection necessary. This is just placing a small cotton ball to serve as a prop for the anterior insert, anterior sylvian corridor, placing of an electrode. When monitoring the face through the leg, I put a 6 electrode strip in there. If only the arm or the leg or the face and the arm, depending on the location of the tumor, then I use a 4 strip electrode. So, and here proceeding with the actual resection of the tumor. In this particular case, fairly straightforward because you can see the tumor is a different color and texture than the surrounding brain. And whenever that can be easily visualized, then we have additional tool, under the microscope to be able to delineate the boundaries of the tumor. This is following the insular resection and going to the posterior orbital frontal region. You can already see this classic speckled appearance of the putamen underneath there as we remove the tumor with the middle cerebral artery branches. And at some point, as an efficient resection of the bulk tumor as possible, I switched to the monopolar stimulating suction. And here you can see the monopolar tip at the end of the suction. I do think it's quite helpful, but it's less efficient for me than a larger suction, which is why I only switch to it when I think that I'm less than 1 centimeter from the cortical spinal tract, simply for efficiency. Different people have different ways of doing
Base at 7.
So for us, what that means is that even here
And at 5.
is that we don't set a
Lower there.
threshold. And what that means is that my neurophysiologist goes wherever I go. So instead of saying that I want to stop or here at 5 milliamps of stimulus, because that's a rigid threshold, wherever I am, he tells me the threshold to the particular muscle that's being monitored. And so that really allows creating a positive dynamic map. And really, I have no limit for which how close we can get. You know, as long as there's tumor, we can get even within a millimeter of the cortical spinal tract or less, and still remain safe. An important thing about that detail is I do not use coagulation or exert heat within 5 milliamps or 5 millimeters of the eloquent tracts. And so it's a cold resection without application of heat. And here you can see as resection pursues that the baseline signals drops in the left biceps. And because I'm confident at not incurring any damage to the surrounding tissue, we simply infuse with saline. You can see the brain bolster up. You see the little jiggle that's running the motors while we're infusing the saline. And with that irrigation, you can then see the signals immediately prop back up, again, confirming the fact that this is a brain sag change and not a true loss of physiologic function with neuromonitoring, allowing us to continue. Here's the lenticular striates being skeletonized and ultimately getting to the end of resection. You can see the nutmeg appearance of the putamen being serving as the anatomic boundary. And just as I mentioned, because I don't coagulate within the depth, so hemostasis is very often simply with a piece of gel foam and a little bit of glue to minimize any risk of ischemic injury from coagulation. I am privileged to have an intraoperative MRI along with these tools. So when feasible, we obtain that. So in this case, you can see a little hematoma in the temporal portion, which is easy to clean up at the end of resection. The brain itself can remain preserved, and having the stable final motors gives us additional assurance for the tempo of recovery of patients, which I think is critical, especially in malignant tumor resection, such as this one. The pathology confirms what we just learned about, which is an IDH wild type glioblastoma from the excellent first talk of this series. And of course, the most important thing is that patients remain well so that they can continue on with their treatment course. So these are our experiences of how to use the tools in glioma surgery.
Thanks, Professor. We will accept questions after all sessions, and we will continue with Professor Dr. Tera. We talk about the diagnosis and the surgery, then we will talk about the advance in glioma chemotherapy, immunotherapy, and gene therapy. Okay,
Thank
Professor.
you so much. Thank you so much to the World Federation of the Neurological Societies, the Neurosurgical Society, and especially to Dr. Manas and Dr. Gilelium for making me a part of this Education Symposium 7 regarding the advances in management of gliomas. After the excellent engaging talks by Dr. Anand, Dr. Albert, and Linda, I would now switch gears to the medical oncology part and talk about the advances in glioma therapy. And especially since we do know about chemotherapy like say temozolomide or irinotecan bevacizumab, or say for instance the PCV regimen. So let's try to look beyond chemotherapy and see what the future has in hold and what the future holds for our patients of high-grade gliomas. Rather than talking the entire gamut, let me try to focus on the high-grade gliomas. And so, are we going to get out of the tunnel? There seems to be some light at the end of the tunnel, but are we going to get out of this tunnel? I will try to focus on multi-kinase inhibitions, some antibody drug conjugates, looking at the metabolomics, targeted therapies, gene therapies, and immunotherapy. Dividing my talk into 6 sections. So in section 1, we'll talk about inhibiting various kinase pathways inside the glioma cell. And so we'll talk about the MKIs or multi-kinase inhibition as an example I'll take this publication in the Lancet Oncology, which talks about comparing regorafenib, which inhibits multiple kinases pathways inside the glioma cells, to lomustine. So these are patients of recurrent GBM who have had at least 12 weeks of completion of radiation, and then after the RT temozolomide, these patients have relapsed. And you randomize these patients in the REGOMA study to either regorafenib or lomustine. And you see that what's important when you're looking at these patients is not objective tumor shrinkage, but even the disease remaining controlled also makes a lot of difference. And so lomustine gives you a 20% disease control rate, which with the MKI regorafenib becomes 44%. In almost half the patients, we end up having a disease control rate. But what's most important in the trifactor of efficacy is, do we have an advantage in overall survival? And regorafenib gives you an advantage of approximately 2 months in absolute terms. With regard to the hazard ratio, 0.50, which means a 50% reduction in the risk of death when you use regorafenib in our patients of relapsed GBM or recurrent GBM rather than when compared to lomustine. Multi-kinase inhibitors like regorafenib possibly are looking at beyond chemotherapy in our patients of relapsed glioblastoma multiforme. So that was about the MKI regorafenib. In section 2, we'll talk about using some potent cytotoxic molecules, which otherwise are so toxic that you can't infuse them intravenously. But however, you tag it to an antibody and make it an antibody drug conjugate. This cytotoxic potent chemical is now only in minute quantities tagged to an antibody. Say, for example, this drug by name dipatuximab mafodotin. So dipatux is essentially bound to the cytotoxin. It now enters the glioma cell and then liberates mafodotin, which is a cytotoxic chemical, a potent microtubule poison. So essentially, you're talking about targeted chemotherapy. The chemotherapy is targeting and entering the glioma cell. And so let's look at dipatux-M being used in combination with temozolomide versus either temozolomide or CCNU in patients of relapsed GBM. And you find the hazard ratio of 0.68. The combination of dipatux-M plus temozolomide is better than either temozolomide or CCNU alone. In fact, 20% of patients are alive at 24 months by adding the antibody drug conjugate to standard chemotherapy temozolomide. And as you can see, the curves are separating beautifully, telling us the advantage of using antibody drug conjugates in the management of high-grade gliomas with relapse or recur. So, and that prompted the investigators to use this molecule upfront. But what's logical may not be oncological. It seemed logical that what worked in the second-line setting so well might actually work better in the first-line setting. But however, in the first-line setting, you found there was no OS benefit at the interim analysis. Very few drugs have ocular side effects. So for example, voriconazole, we all know can cause some ocular toxicity. Similarly, this drug also can cause reversible ocular toxicity. So antibody drug conjugates can cause eye side effects. And if you keep a watch on that, then it would be a reversible adverse event. And that's why carefully monitor your patients if they are put on temozolomide plus dipatux-M. So that was about antibody drug conjugates. In my third section, we all know about genomics, proteomics, and transcriptomics. The era is now coming. In the future, we'll talk about metabolomics, talking about the metabolome of the glioma cell or the cancer or the neoplastic cell. And so in neurology, in neurosurgery, we talk about some molecules like ornithine, putrescine, spermidine, and spermine. Now, this is basically the polyamine metabolism. Looking at the amines like ornithine getting converted to putrescine and then spermidine and spermine. The enzyme ODC, ornithine decarboxylase, converts ornithine and then the polyamine metabolism goes forward. There's a drug by name eflornithine which inhibits this enzyme ODC, ornithine decarboxylase. So what does ODC do? Constitutive elevation of this enzyme triggers tumorigenesis. It continues to have the transplant phenotype. As the grade of the cancer increases, the levels of this enzyme keep on increasing. And that's the importance of ODC as a cancer and especially glioma target. And so if you could use a drug by name eflornithine, which is a ODC inhibitor, it inhibits the enzyme ornithine decarboxylase. So this was a phase 3 study where patients of anaplastic astrocytoma went on to receive either PCV or PCV plus eflornithine, and they found that the median overall survival improved 2.8 years. So that clearly tells us that we are not looking at an advantage in just response rates or progression-free survival, but looking at a real overall survival advantage happening in these patients when you try to target the metabolomics, the polyamine metabolism, for instance, by using this drug by name eflornithine. Of course, when you add one more molecule to a triplet of, say, the PCV chemotherapy regimen, you might have some increase in adverse events. But as you can see in the box, the adverse event increase is in the range of 2 to 12% only. So not a great accumulation of adverse events. In section 4, if we can identify a druggable target, like say for instance, anti-RK fusion or BRAF mutations, then you could actually use drugs which can target these druggable targets. And that you do by doing what is called a CGP, comprehensive genomic profiling, by next generation sequencing. And so ushers in the era of targeted therapy in the management of high-grade gliomas. For instance, this therefore becomes precision medicine or precision oncology. So this was a clinical trial looking at 18 patients of primary CNS tumors who had the anti-RK fusion present by molecular profiling. And the endpoint was to look at the objective response rate. So we use a drug by name larotrectinib, which is an anti-RK fusion inhibitor, and you look at 14 eligible patients, 14 evaluable patients to see and get an objective response rate of 36%. A simple oral pill, larotrectinib, is able to target these TRK fusion positive primary CNS tumors. Now look at the disease control rate, 14% complete responses, 20% partial responses, 64% stable disease. So 100% disease control rate, essentially no progressive disease at all. And the median progression-free survival is close to a year, 11 months. Similarly, in a recurrent refractory solid pediatric tumors in the central nervous system, there is a drug again by name entrectinib, which also is an anti-RK fusion inhibitor. And so you end up getting measurable and durable responses in these anti-RK1, 2, 3 or ROS1 positive tumors. So that's the beauty of identifying druggable targets and then using drugs which can target these abnormalities specific only to that glioma or CNS tumors. Fifthly, we'll talk about glioma gene therapy. And I would definitely suggest all of you to look at and go through this article which was published in the Frontiers in Molecular Neurosciences, talking about glioma gene therapy and virotherapy, which means therapy with oncolytic viruses. Virotherapy involves the use of oncolytic viruses. And in this article, you have two figures where they talk about oncolytic viruses, how they induce glioma cell death on one hand by infecting the cells and killing them. On the other hand, when these cells die, they start liberating not only the viruses which infect the neighboring further glioma cells, but they also cause the liberation of various tumor-associated antigens, chemokines, type interferons, and damage-associated molecular patterns. So an oncolytic virus enters the glioma cell. The glioma cell is killed because the virus replicates, and then these viruses further infect the neighboring glioma cells. More than that, they also liberate various tumor-associated antigens, and that alters the atmospheric milieu in and around the tumor, which causes recruitment of various defense molecules which are involved in immunosurveillance, like the CD8 positive T cytotoxic lymphocytes, antigen presenting cells, memory CD8 positive T cells, and that leads to a cytotoxic response by these natural killer cells and cytotoxic T lymphocytes. The second figure in this article talks about the EK-FLT3L gene therapy, which essentially involves the usage of first-generation adenoviral vectors. And these adenovirus vectors encode the thymidine kinase and the FMS-like tyrosine kinase 3 ligand. You inject them into the tumor cavity following surgical resection, and then you end up with all these 6 patterns happening here, including first starting with the dendritic cell recruitment to the tumor microenvironment, then causing the immunogenic cell death of the glioblastoma multiforme cells, also resulting in presentation of the tumor antigen to dendritic cells, trafficking of the activated T cells, finally causing cytotoxic glioma killing by these activated T lymphocytes, ultimately resulting in anti-GBM immunological memory. And it is this memory which, as immune surveillance, can prevent recurrences or relapses, or maybe prolong them for a much more longer time to result in improved progression-free survival, ultimately resulting in an improvement in the overall survival. The future, therefore, seems to be glioma gene therapy involving various oncolytic viruses. And I showed you these 2 figures in this excellent publication talking about the future being glioma gene therapy. Let's all hope we will be able to use and exploit the advantage of these anti-glioma gene therapies. And lastly, I'll end my section with this section 6, which talks about immunotherapy or using the immuno-oncology molecules in the management of gliomas. It essentially talks about unleashing the force within, and that's why immuno-oncology molecules bring a new hope to cancer treatment. The Checkmate 143 trial looked at bevacizumab as single agent compared to nivolumab as the immuno-oncology molecule in recurrent GBM. And what they found was the response rates with bevacizumab are 23%, but only 8% with nivolumab, the immuno-oncology molecules. But the median duration of response, so in those patients who respond, when the numbers are small, but the duration of response is close to an year. So though the numbers of patients who respond might be less, but in those patients who respond, the response lasts for a longer time, almost double when compared to bevacizumab. Similarly, you are finding no improvement in the progression-free survival to your right with nivolumab, but it doesn't hamper the overall survival. It remains 10 months with either nivolumab or bevacizumab. But then we want an improvement over the current standard treatments. And that's why this phase 2 study in recurrent GBM looked at adding bevacizumab to the immuno-oncology molecule pembrolizumab, expecting that adding pembro to the anti-VEGF treatment, which means an IU and anti-VEGF combination, possibly might be better than immunotherapy alone. And unfortunately, again, here too, you could not find a major improvement when compared to single-agent IU molecules. And that's why we need to question, why is it happening that immunotherapy is not working so well in high-grade gliomas, which recur or relapse? Importantly, it is also linked to the dexamethasone usage. We know immunotherapies are going to stimulate the body's immune defense cells, and then these immune cells will ultimately attack the neoplastic cancer tumor. But dexamethasone, if it's used, then dexamethasone will cause immune suppression, and that's why it can blunt the immune response which we expect with the immunotherapy molecules. Number two, it's all about biomarkers. In newly diagnosed glioblastoma, 1/3 of patients will be having overexpression of PD-L1 in more than 5% of tumor cells, whereas in recurrent GBM, this drops down to only 17%. Not only that, once you use an anti-PD-1 or a PD-L1 antibody, then since you have blocked that, the tumor cell is able to activate and produce what's called as CD38. And CD38 will now cause dampening of the T cell activation. And so let's look at to your left, the tumor PD-L1 is blunting the T cell activation, inhibiting T cells. And so when you block this by using nivolumab or pembrolizumab, then CD38 gets overexpressed, which again prevents T cell activation. And so you can possibly use a combination of anti-PD-1 and anti-CD38, because then you can block both PD-L1 and CD38. So by targeting CD38 by using the anti-CD38 antibody isatuximab, which becomes a second checkpoint inhibitor. The future, therefore, is talking about using an IO molecule plus an IO molecule, which is double immunotherapies, and that possibly might be able to improve the response rates with the immuno-oncology molecules. Thirdly, mismatch repair deficiency or microsatellite instability also predicts the response of solid tumors to PD-1 blockade with either nivolumab or pembrolizumab. So one is to reduce the dexamethasone usage to say 4 milligrams or less. Second is to look for the expression of PD-L1 and try to use double antibodies like anti-PD-1 or anti-PD-L1 and anti-CD38 active. And third is to look for mismatch repair deficiency or MSI instability. And so this trial of pembrolizumab in a recurrent high-grade gliomas, trying to look at only those gliomas which had mismatch repair deficiency. And as you can see, they learned the lessons from the previous trials and so limited the use of dexamethasone to 4 milligrams or less. And now you find out of 12 patients, 4 patients had a disease control, 33% disease control rate. And when compared to the 67% of patients stable disease who had progressive disease, patients who get control of disease by using immuno-oncology molecules have a cumulative improvement in the overall survival. So with immunotherapy, you are not looking at tumor shrinkage. It can be a stable disease or a partial response, but as long as this is not progressing, these patients will have an improvement in overall survival. So I tried to therefore bring across 6 different sections, trying to tell you and giving you a flavor of what multi-kinase inhibition is, antibody drug conjugates, what they can do, using targeting the polyamine metabolism, the metabolomics, target therapies, gene therapy, and lastly, immunotherapy. Thank you so much, one and all, and especially Manas Bhai and Dr. Zilelim for making me a part of this wonderful neurosurgical conference.
Also, thanks, Professor. Most of the drugs we don't know, but I think we will reach in the near future. And I think we have some questions from audience. So Albert Spinal already answered some of them. Professor Spinal, can you answer for the other audience questions? Spinal, are you there? I think he's not here.
Yeah, I think Dr.
Professor, you always answered the questions from messages, but could you answer again to other audience?
Okay.
In one of
What
our
about
audience
question? Question for me?
Yes.
Okay. What kind of question?
No, you already answered from the messages, but
yeah, okay,
could you
okay,
explain for the
okay.
other audience?
Okay.
So yes, Dr. Albert has already answered all the questions, and because we are already late, and then we have another webinar to follow. I think we should thank all the speakers for giving an excellent overview and of the topic. As you can see, a lot of comments in the message in the chat box, and I hope we have another webinar on this topic, because it's a webinar something which is difficult to understand, and we need repetition of this webinar to actually understand and practice in our patient. And request Dr. Jalali to give final comments, or any of the speakers want to give final comments, then close the webinar.
I think we can close the webinar because
There is another timed webinar I will be there after a few minutes. So thank you, Dr. Anand, Dr. Albert, Dr. Linda, and Dr. Dattatraya for spending the time on a Saturday evening to be part of the webinar. And I'd like to thank Dr. Abuzar also to participate and spend the time, and all the delegates, almost more than 120 are interested in the topic. Over to Professor Jalali.
Thank you very much, sir.
Thank you very much. Thank you.
Thank you so much.
Thanks, everybody, in the first part. And then we will now switch to another symposia on management of spinal cord injury. Dr. Sergio Salvador will be the moderator. Actually, I think Dr. Jesus will not join us. Yes, Sergio, you can start it now.
Good afternoon, where I am. Good morning, or good evening, depending on where you are. Thank you, Professor Jalali, for organizing this symposium, this 8th symposium on management of spinal cord injury. So we will start with Professor Andres Rubiano, speaking on early care and transport. Professor Andres.
No. Hello.
Yeah.
Hello,
Hi, Professor Salvador. How are you? Okay.
Hi, welcome, Andre.
Hi, Professor. Thank you so much. I'm gonna share my screen.
Yeah, please.
Okay.
We have 15 minutes for talks and then discussion.
Okay. Okay. Thank you so much for the invitation. We are going to speak about early care and transport of spinal cord injury patients, very focused on the management. So there is no conflict of interest. We are part of the NIHR Global Health Research Groups on acquired brain injury, brain and spine injuries. We are going to start briefly with the knowledge of the burden of disease. This is the most recent study of the global burden of disease, showing how injuries that are in the green box, in the boxes in the top bottom of the slide, is increasing, especially in young population. In the middle, we have the amount of diseases between 5 and 14 years old, and then 15 to 40 years old. So we see how the green boxes are increasing. Specifically talking about spinal cord injury, there is a huge evolution of the process. In the last 30 years, it have increased a lot. Males and the elderly were more affected than females and younger individuals. And the sociodemographic index is correlated directly with the spinal cord injury incidence. So this is also associated that most LMICs does not have a specific registries to report the condition. So it's regularly more reported in areas that have more resources. Talking about pre-hospital and early care, we have several set of guidelines, consensus, and recommendations. We're going to start briefly mentioning that since 2010, there have been many systematic reviews talking specific about these specific topics. Also, we have in 2012 the ENLS program from the Neurocritical Care Society with a specific recommendation for emergency management of traumatic spine injury. We have the WFNS guidelines that was published in 2013. We have some recommendations regarding pre-hospital cervical spinal immobilization, transportation, clinical assessment, radiographic assessment, and medical treatment. Then we evolve with more set of guidelines. We have the early management recommendation for the World Federation Spinal Committee group. Then we have the clinical practice guidelines, specifically talking about the use of methylprednisolone that was published in 2017 also. Then we have in 2023 the best practice guideline of the American College of Surgeons related to spine injury. More recently, we have the AO clinical practice guideline for the management of patients with acute spinal cord injury, published in 2024. And one group that was published, we recently published this set of clinical recommendations consensus for patients when they have a spinal cord injury and initially they have polytrauma. This was endorsed by the World Journal Association of Emergency Surgery. So in the middle of many of these different set of guidelines and recommendations, we are going to speak briefly about what is the actual status of the initial management since the pre-hospital transport and also in the emergency care room. We are know about the pathophysiology of spinal cord injury, many of the different mechanisms and how these have been identified into the molecular profile that has been associated with some biomarkers that can identify different stages, including the blood-brain barrier leakage, the microglia damage, the infiltrating immune cells process, angiogenesis, gliosis, axonal sprouting, and neurogenesis that comes from hours to months. So many of these have been analyzed in depth in many review articles. So for the pre-hospital care perspective, we have three main points that still are very valuable. We need to teach these teams how to do early clinical recognition and also use the selective immobilization criteria. So we are sure now that we don't need to put cervical collars on all patients. Also, we need to do a lot of emphasis regarding the management of hypoxia and hypotension. And we definitely need to generate early transport to the nearest center with capabilities, including radiology, neurosurgery, and ICU. So since the 2013 WFNS clinical practice guidelines, many of these recommendations have been performed specifically about how to do the immobilization. Definitely patients who are awake, alert, and not intoxicated, who are without neck pain or tenderness, who do not have any abnormal motor or sensory examination, and who do not have any significant associated injury, do not need a specific immobilization. A combination of rigid collar and the backboard with maybe supportive blocks is the main strategy when we decide to immobilize the patient. And we need to transport the patient as soon as possible with the center with better capacity. I addition here one of the recommendations that have been also transversal in many of the guidelines and consensus is the ASHA scale is the preferred clinical evaluation tool for acute neurological assessment in these patients. So we definitely need to also promote between the pre-hospital providers to teach them how to use the ASIA scale. Moving to the emergency room, we have some of the recommendations of the World Society of Emergency Surgery that I just briefly mentioned. We have the algorithm that they published. We were very supportive of highlighting that patients that have polytrauma and also spinal cord injury need to have an appropriate aggressive resuscitation since the beginning. So we manage all these patients with several of these thresholds that have been mentioned here in the consensus. There are around 17 or 19 recommendations that focus in many of these aspects. What are the best hemoglobin criteria, respiratory and arterial blood gases criteria, coagulopathy profile, also some of the variables for mid-arterial pressure, and how to use some different tests to evaluate the bleeding conditions in these patients. Also, the emergency neurological life support spinal cord injury section do specific recommendations about when to intubate these patients, when we have obvious respiratory distress or dyspnea, when we have complaint of inability to catch the breath, inability to hold the breath for 12 seconds, when vital capacity is reduced less than 10 milligrams per kilogram. So many of these aspects need to be taken into consideration for the aggressive initial intubation of these patients. We also highlight here that has been addressed by the 2013 guidelines, the World Federation of Neurosurgical Society Spine Committee recommendations in 2017, and the American College of Surgeons Spinal Cord Injury Best Practice recommendation from 2023 about the use of the Asia scale and the Asia score in order to evaluate appropriate these patients. So related that neurological examinations in the emergency room, we already mentioned about the American Spinal Injury Association international standards that need to be taken into account. There are also some mentions about the spinal cord independence measure as the preferred functional outcome assessment tool. It has been also endorsed by the 2013 guidelines, the 2017 World Federation recommendations, and the 2023 American College of Surgeons best practice recommendations. Additionally, we have some set of recommendations regarding initial imaging. Definitely the CT is the standard of care in centers that do not have too much resources. Even if there is not CT available, we can use X-rays, but X-rays are not the first option, and these need to be highlighted. And definitely the MRI is the only study that can allow us to see the content of the intraspinal canal. So all these need to be very well established, is endorsed by the 2013 guidelines, the 2023 best practice recommendations of the American College of Surgeons. Regarding the instability hemodynamic management, the recent AO spine guideline has been very supportive of maintain a specific threshold of blood pressure. In this case, the recommendation is to manage at least a mean arterial pressure of 80 millimeters of mercury, but not higher than 90 to 95. And when you talk about how to do it, there are some specific sort of discussions regarding which medications are going to use, especially for patients that have spinal shock and also neurogenic shock. So there have been some recommendations related to norepinephrine and also some chronotropic and inotropic medications, according to the recommendations of the World Federation Spine Committee in 2017. Additionally, this same set of recommendations established that early surgery within the first 8 hours should be performed in most of the cases. If feasible, these patients need to be treated in a specialized level 1 neurotrauma center. As we mentioned before, for the transport, patients need to arrive to centers that have neurosurgery availability, imaging availability, and also ICU availability. Regarding the choice of vasopressors or inotropes, the recent AO spine guidelines does not do a specific drug recommendation. They mentioned that the choice of vasopressor or inotrope is dependent on several patient factors, including the presence of a central line, concurrent cardiopulmonary dysfunction, and comorbidities. The decompressive surgery has been recommended also by the AO recent spine guidelines 2024 in the last 24 hours, in the first 24 hours. The best practice recommendations of the American College of Surgeons also highlight the possibility of, since the emergency room start evaluating the patient with the AO spine trauma classification, all these different set of classifications that we already know very well. They are easy to use, comprehensive, and address some shortcomings of the SLIC and TLIC systems. Regarding pharmacological management, the 2013, the 2023, and the 2024 consensus and guidelines have in common that they do not recommend the use of methylprednisolone, but they also highlight that there is no other potential therapeutic agent that have demonstrated some efficacy for motor recovery or neuroprotections. As we mentioned before, we have a very specific clinical practice guideline in 2017, led by Professor Felix, regarding some more insights about the use of methylprednisolone. They definitely do not recommend to use a 24-hour infusion of high dose of methylprednisolone to other patients who present after 8 hours. They left a very weak suggestion regarding the option of using in the first 8 hours. And definitely, they do not support the use of 48 hours infusion in these patients. Before finish, I just want to highlight some of the work that we have been doing regarding how to implement many of these different set of recommendations and guidelines, specifically in areas that do not have too many resources. We have been doing a lot of surveys in different regions of the world. There is one of the more recent ones with 1,145 participants. If we go worldwide and mention how, if people is familiar with many of these guidelines, definitely, specifically neurosurgeons are more aware, and also neurosurgical trainees, but not really orthopedic surgeons. And if we have the blue bar, that is all the specialties together, the World Federation of Neurosurgical Society recommendation for 2017 is only in the knowledge of 50% of many of these people. The WFNS CNS guidelines in less than 30%. The NICE guidelines of the British government in less than 25%. And other guidelines like the AO guidelines in less than 10 or 15%. So one thing that we need to know is that many of these guidelines are there, but many of the people that is taking care of the patient, especially in LMICs, do not know that set of guidelines. So we need to do a better job in order to spreading the content of these guidelines worldwide. And also, we recently do an analysis also in many regions of the world related to some of the recommendations, and we found the same trend, and especially in areas like Africa, Latin America, many of these recommendations are not applied to or applied to many of the patients in different regions of the world. We specifically asked about arriving to facility with cervical collars, receive CT for cervical spine diagnosis, use of 3-view radiographic assessment if CT is unavailable, the doses of corticosteroids, the maintaining of the mean arterial pressure, and the early surgical management, and it have a wide variation according to the region of the world. This was another survey that we did regarding the early care in many regions, especially in more low-income settings. There are no pre-hospital systems available, so many people is not managed according to many of the recommendations because there is not their EMS management. For cervical restriction, you see the small map. Green are areas where they applied the recommendation. Red and yellow are areas that they do not apply the recommendation, only occasionally. We also have the initial imaging cost. You see that in many regions of the world, especially Africa, Southeast Asia, and some areas of Latin America, people need to pay for the initial imaging. So this generates an important restriction of availability for many of these recommendations in many of these areas. And the last survey that we did was related to ICU management and early surgery. So in many regions still, if you see the more low-income settings that are under the word A here, at least 80% of the countries do not have immediate ICU available for patients, either if they have been operated or not. So many of these patients are returned to general wards and not to ICU for managing all these recommendations from the guidelines. And when we speak about timing to surgery, you can see in the map still many areas that have a lot of red. That means that patients do not have access to surgery in the last 48 hours. And also, if you see, many of the costs of the initial surgery need to be managed directly by pocket expense for the population. Also, rehabilitation is not always available. Many of the rehabilitation for these patients is performed at home. I just want to mention that because of many of these variations and heterogeneity, what we have been working is on the concept of bootstrap spine. We are all familiar with the concept that we propose regarding bootstrap for traumatic brain injury. That is beyond one option for treatment of these conditions. So we just recently finished. We are going to work in the final draft of the document. Because when we are in many of these regions of the world, if you talk, for example, about pre-hospital care, you can have pre-hospital care of very low resources, some sort of resources, of all the resources. You can see this the scheme here with the blocks. Green blocks are centers that have all the resources. Red centers are centers that do not have all of the resources. Yellow centers are centers that have some sort of the resources. Then you move the patient to a facility in the emergency room that either can have access to early image, like is the gray box, or centers that do not have early image, either with low conditions, middle conditions, or high conditions or resources. And then you can move to centers that have immediate spinal surgery availability, either by a neurosurgeon or either by an orthopedic surgeon, or centers that do not have early access to neurosurgery or orthopedic surgery. They only have sometimes general surgery care. And then you can have to centers that have postoperative ICU care availability, or centers that do not have postoperative ICU care availability. So we need to set a specific guidelines or recommendations for each one of these different set of settings. And what we did in the last World Federation of Neurosurgical Society Congress in Bogota was specifically doing this, and we are going to publish soon all these set sort of recommendations. Also, to remember that with the Global Neuro Trauma Research Group and also the Acquired Brain and Spine Injuries Research Group, we have been doing this global neurotrauma outcome study led by the University of Cambridge. Is there available for people that want to register. Is just a snapshot of how are the outcomes of these patients correlated with the initial management in different regions of the world. Actually, there are 222 hospitals entering data in 54 countries with more than 848 collaborators, and this is totally open to the community worldwide. So thank you so much. Many of these issues are part of what we are teaching and doing with our fellows in our neurotrauma fellowship program in Colombia. So this is something that is really important and need to be connected with the next stages of care. We are going to mention many of these discussions here also. So thank you so much. And these are the centers that we are doing many of this work, and with our local research center, Meditech Foundation in Colombia. Thank you so much.
Thank you, Professor Rubiano, for your excellent presentation. We proceed with Professor John Oma, speaking on cervical traction, close or open reduction. Professor Oma, please.
Good. Thank you very much. I'll just share my screen now. Thank you. Let me start from there. I hope you can see my screen. Good.
Yes, we can.
Yes, so thank you very much for the invite. I'm just going to spend the next 10-15 minutes speaking about this question of cervical traction, closed or open reduction, something that I'm sure all the participants in this Zoom meeting are well familiar with. Nevertheless, it is a good thing to go over, familiar territories. So very briefly, the cervical spine, as we all know, is, has its unique anatomy. And I don't think one really needs to, to elaborate much about this, but the specifics about the articulation of C0, which is the occiput, C1 and C2, very unique synovial joint and ligamentous sort of orientation that maintains its stability. And then, of course, the subaxial spine, which is quite different. We know that the C0, C1, C2 area, apart from those unique joints that join them, we also have this washer sort of function of C1, which serves almost as a washer between the occiput and C2. And it's a very unique sort of situation. There's a lot of room for the spinal cord in that area. And so when we talk about destructions in the cervical area, we rarely sort of mention or rarely discuss, issues around that area for reasons that I will go into just now. The subaxial spine, however, is by far the commonest area that we're involved with when we come to traumatic compression of the spinal cord. And perhaps the reason for that is the fact that the spinal cord has far less space, available to it in the subaxial spine, as well as the fact that this part of the spine has these discs in front, apart from the vertebral bodies, large vertebral bodies and discs in front, all of which can compress the spinal cord in certain situations, as well as when you look posteriorly, this unique arrangement of facet joints, which, as we shall see, and as we all know, again, under certain conditions of trauma, can become the compressing lesions. So, why do we need to decompress the cervical spine? Now, this is an obvious question, but I'll just go through the obvious answers. So, the spinal cord cannot tolerate compression. And once there is significant compression, there is obviously direct trauma to the spinal cord, as we saw in the first talk. There are all the minor molecular changes that happen once you have ischemia and that kind of trauma, a reduction of blood supply, worsening of ischemia, the question of instability, worsening the neurology, pain, and so on. But also the fact that the faster we decompress a compressed spine, the better, the neurological outcomes. And by the same token, with any delay of decompression, we obviously have significant outcomes, which in the case of the cervical spine can be completely disastrous. So I think the question of why is not really important. This question also is another obvious one. What are the causes of post-traumatic cervical cord compression? Now, again, there are many. You could have bony fragments, etc. But I just want us to concentrate for the purposes of this talk on the facet joint subluxations, which in fact are, I would say, certainly in our practice, the commonest reason why we suddenly have to jump out of bed and start decompressing a spinal cord. So that's what I'm going to concentrate upon. So what are the facet dislocations of the subaxial spine? Essentially, what we have in the subaxial spine is this unique arrangement where the facets lie in each other, the superior one lying posterior, or the inferior facet of the superior vertebra lying posterior superior to the inferior facet, or rather to the superior facet of the inferior vertebra. It all sounds like a word salad, but I'm sure you all get what I mean. So there's this unique arrangement which, under certain conditions, specifically flexion destruction, one can have a situation where there is significant flexion and destruction resulting in the first case, that subluxation and then perching. And should that continue, this particular facet coming to rest in front, or the inferior facet coming to rest in front of the superior facet, and that creates a situation where the spinal canal gets compromised and the spine gets compromised, and there could be other issues as well in terms of what happens to the disc, which too may move and may become part of the problem. In addition to that, depending on the nature or the vector of the force, one could also have fractures. So you may not just have a dislocation or subluxation of the facets, but you could also have a fracture dislocation where either one or both of the facets fracture. By the same token, you could have this on either one side, in which case we have a unilateral problem, or both sides, in which case you have a bilateral problem. So unifacet dislocation is a unique one. And the thinking is that in addition to the flexion destruction mechanism, you also have a bit of a rotation mechanism, which favors the one side favors or disfavors the one side in terms of the fact that that facet experiences far more stress and jumps over its facet, over its inferior facet, whereas the one on the other side doesn't. Now, this is a unique situation. It has been described as the most missed injury, cervical injury. In other words, unifacet dislocations are the most missed injury, in casualties across the world when it comes to cervical spine trauma. And it's easy to see why it can be missed if one is not very careful. If one looks at these X-rays, without paying too much attention, one may miss some of the obvious signs. And one of the signs that we see with unifacet dislocations, this so-called bow tie sign, which has been shown here. The other sign that has been talked about is the reducing laminar space. If you look at the laminar sort of space from your spinal laminar line to the posterior vertebral space, when you have these unilateral facets, it sort of tends to decrease. So one has to be careful. Otherwise, one can miss it. And, and that can have disastrous consequences for the patient. However, bifacet dislocations in our practice are the commoner dislocations of the subaxial spine that we see. One of the things that you immediately notice is that when you have bifacet dislocations, the subluxation tends to be, at least like a grade 2 and above. You get these large subluxations. With the unifacet, you may get like up to 25% or no more than that. But here you get your 50, 75, God forbid, you can get a complete spondyloptosis. When one looks at the CT scan axial sections, again, we're all familiar with the hamburger sign, the normal sign or the normal situation, the so-called hamburger sign, where we have the normal facets, as well as the headphone sign. I'm sure we're all familiar with the headphone sign, where you've got the uncinate processes of the inferior vertebra sort of acting as a headphone on the superior vertebra. And all this gets lost. If you've got a bifacet dislocation, it looks like the hamburger is now sitting inverted and the headphones are lost. So these are just some of the signs that one can look for, perhaps just for the benefit of some of the younger members of the meeting. All right, so now I'll just come back to the nitty-gritty of this talk, which is really about reducing facet dislocations. I just want to concentrate on facet dislocations. So how do we reduce facet dislocations? Now, there are really 4 main ways in which we do that. And I'll go through each one by one. So cranial traction, or so-called tongue traction or Gardner-Wells traction is probably the most known and I would argue the most used technique around the world. It's certainly the one that is perhaps easiest to implement in a casualty situation. But interestingly enough, if you go around, especially many primary tier and secondary tier hospitals, and ask to see the tongues or the Gardner-Wells tongues or skull traction tongues, many times they are not available, or if they are available, one half is missing and so on. And this is a huge problem. Even where they're available, the knowledge as to how to use them is a problem. And this, as I'll explain in future slides, is a significant problem because cranial traction, even though it's highly effective, it is not generally used as well as it should be at the point of first contact. And many of these patients eventually are transported over many hours and many miles to a place where they can be assisted long after the window of opportunity has passed. So manual traction is another one we'll talk about. And then, of course, the open approaches, which may be anterior and posterior. So again, just to go through the obvious for many people here, the cranial traction, which employs, in its commonest form, Gardner-Wells tongues or various other tongues that are applied to the skull. But there are problems with this. The patient must be awake because you're going to distract the dislocation. You've now diagnosed that there's a subluxation and you're going to apply pressure in order to try and pull this. Usually, you apply pressure in flexion, because if you apply an extension, you tend to lock the facets. It has been said that if the facets are fractured, then they tend to reduce much easier, and that's perhaps true. Otherwise, you distract the patient in flexion, which is in a sense the same manner in which they actually sublux in the first place. And once a facet's purged and you relax it, you then come down. We all know that we usually start with around 5 kilograms weight, X-ray to make sure there is no atlanto-occipital issue, and then increase the weights every 10 minutes by, say, 2 to 5 kilograms per level until we get patching, and then we reduce and allow the facets to reduce. There are a number of problems with this. I've mentioned that many hospitals in the primary and secondary care setting where the patients do arrive don't have these devices. If they have them, they haven't been used for 6 months. So when a patient arrives, nobody knows where it is, or the screwdriver is missing and so on, and that's a huge problem. You also need to know the techniques as to how to attach the pulley. You need to know about, say, the 2-mattress mechanism. You need to know about the directions, destruction inflection, destruction neutral, destruction extension. And there has to be a mechanism for repeated x-rays, presumably a C-arm, like in your casualty setting, where you can repeatedly x-ray, because you can't be putting weights and not getting real-time or frequent x-rays to see what you're doing. So these are the problems. And on top of that, you must commit to examining the patients neurologically to see that they're not deteriorating. So all these are the problems with this technique. Nevertheless, I think there's room for education and improvement in the way this technique is done. So what about manual reduction? Now, this is another very interesting technique. And as I'll show later, it has been touted to be far more effective and perhaps far better than the skull traction that we talked about. So under manual reduction, one goes to theater, takes the patient to theater under general anesthesia and relaxation, and one manually reduces the dislocation. Now that sounds perhaps horrendous to some of the purists who grew up only using cranial traction, but in fact, there's a lot of literature that suggests that in fact, we should rather be doing manual traction because it's quicker, it's easier, and the argument about neurological deterioration has been countered by the fact, or by the argument, the counter-argument, that in fact, if you reduce these patients as soon as possible, you're doing them a much bigger favor than if you try to reduce them with the cranial traction over many hours sometimes, and not really knowing where you are. You'd rather have them asleep, reduce them, wake them up, examine them, and then, if there is a problem, deal with it. So this has been, and there is literature I'll show that suggests that this is the manner in which we should be doing things. And then, of course, the open techniques. Now, open reduction techniques, many patients, usually the open and closed, rather the open anterior and posterior techniques are usually used as a second or as a fallback measure where the closed techniques have failed. So for instance, you apply skull traction and after 4 hours, you still nowhere, then you decide, well, let's go to theater and reduce this. And so what happens, there are many techniques, but this is the one with the cloward, rather with the Casper pins and the intervertebral destructor, where one tries to get either a Casper pin destruction or an intervertebral spreader under real-time fluoroscopy to make sure that as you do that, you actually watch the facets dislocate. Once they patch and then go back into position, you then reduce your destruction. So that is the open technique, and the advantage being that you can then at the same sitting complete the fusion, usually in this case an ACDF type fusion. Posteriorly, one can also do this posteriorly, and with the posterior technique, again, one opens and one essentially physically gets, in this case, this is an illustration of a unifacet dislocation, where one physically gets the facet back in its place. And there are many techniques described with the bifacet, for instance, putting retractors on the spinous processes and distracting them in flexion until they return to normal. And then once that is done, one can then complete a posterior fusion. So as one can see, there are many ways of skinning the cat. However, that's perhaps the easy part. For the last part of my talk, I'll talk about the controversies, which is really the hard part of this whole question of facet dislocation. There are a number of controversies, and it's well worth going through them. And the first one is the question of a pre-reduction MRI. Is it ever a necessity? Now, if you want to get spine surgeons hot under the collar, you should just start this discussion, because people tend to have very strong positions on either side. And I think the truth is perhaps somewhere in between. Is it ever a necessity? I personally think that where patients are intact neurologically, and we do get patients who are intact neurologically, even sometimes with bifacet dislocations, intact, or at most they just have perhaps a radical that's weak and so on. In cases like that, the question is, should you get an MRI? Because the patient has everything to lose if anything goes awry during the reduction. So one would argue that if an MRI is accessible and the patient is intact, it may be an idea to get an MRI to ensure especially the behavior of the disc. Say, let's say we're talking about a C5-6 subluxation. What is the disc at C5-6 doing? Because not infrequently, these discs have moved back and they're sitting behind the body of C5. And when you achieve your reduction, you now have a reduction with a huge disc in the canal space causing acute spinal cord compression. So that has been rubbished by many as either infrequent or not significant. There is literature that says that even where that is the case, and you reduce the disc, patients do not necessarily deteriorate and so on. And so one should not waste valuable time getting an MRI. But I still think that if an MRI is accessible and the patient is intact, then that is something that should be looked into. In other cases, I'm not so sure. The other controversy is how quickly should reduction be achieved, and I'll show you one aspect from the South African courts. What is the most effective method of reduction, which speaks to controversy number 2? Should we be teaching our students skull traction as a primary method, or should we be encouraging manual reduction? At what point should we be advocating for open reduction? So these are all controversies. The strategy between uni and bifacet dislocations, there is literature suggesting that unifacet dislocations are particularly difficult to reduce with skull traction. And I don't know, we'll perhaps hear from other panelists if that is the experience. And then, of course, the controversy of anterior versus posterior. So just to rush through this, I think I have 5 minutes left, but the question of pre-reduction MRIs, as I've said, there is a lot of literature, and I've just highlighted some of the literature, and you could actually fill 10 pages with the literature arguing for or against pre-reduction MRI. The reality is many places where patients arrive at with bifacet dislocations or unifacet dislocations do not even have an MRI anyway. And so it would be wrong to expect people to wait or to transfer patients without dislocating them because of MRIs. But I still think that one has to be careful where the patients are intact neurologically. There is, I think, a role for that. But in other cases, I think I'm quite happy to suggest that we should be reducing the patients as soon as possible and then obtaining MRIs if we can, or for that matter, CT myelograms or whatever else we are able to get if there is a concern about the neurology. How quickly should reduction be achieved? Now, the South African courts in 2015, there was a case involving a rugby player who had a bifacet dislocation, and there were a lot of things that went wrong, and I think the reduction only happened after 14 hours. In any case, the matter ended up in court as a negligence case, and ultimately it was argued all the way to the Constitutional Court, which has now made a declaration that these facet dislocations should be reduced within 4 hours of injury. So this now, for those practicing in South Africa, is now law. And it's something that in every spine meeting we have, is sort of a source of much amusement, because in many cases, the patients do not even arrive at the first point of center or the centers where reduction can happen within 4 hours. And so where does that leave you if a patient has arrived 5 hours or 6 hours after the injury? I mean, the courts say there must be a reduction within 4 hours. You're now in negative time and so on. And again, even if the patient arrives within an hour or so, and you're reducing the patient with cranial traction, which is a recognized method, and now it's 1 hour and 2 hours and it's not happening. I mean, at what point do you abandon this and get to either manual traction or open reduction if you're having one eye on the patient and one eye on the law? And finally, who says 4 hours? How do we know what the spine can tolerate? And so there are all these questions. And so the question, would all agree that it should be as soon as possible? There can be no argument that a spine should not be under pressure, but the question of whether these things can be stated in law, as in 4 hours or 2 hours or 5 hours, is, I think, highly controversial, and it will remain controversial, till the end of time. What is the most effective method of reduction? We spoke about this earlier, about the different methods, and I've just I've just used these two papers more than 10 years apart. This one from China, sort of talking about the essentially reduction, manual reduction versus cranial traction, showing that actually this ZR technique, which is the Z-shaped manual traction, is safer and more effective than the traditional skull traction for close reduction of subaxial facet dislocation. This is another paper. It's been around for much longer. And again, even these people who reviewed over 4 years manipulation for cervical dislocation under general anesthesia also showed that this is a safe and effective procedure for pure cervical spine dislocation. So the reason I'm putting them up here is because there has always been a source of concern. How do you put people under general anesthesia if you cannot assess them? Because we always emphasize that when you reduce these dislocations, you must be able to monitor them neurologically. How then do you advocate for reductions under general anesthesia when you cannot monitor patients? But in fact, the literature suggests that that's not an issue, that in fact, you should reduce them. The reduction is what's more important rather than monitoring their neurological state. Because once you reduce them, you're saving the cord from further injury, and then one can take it from there. So this remains one of the confusions. Anterior versus posterior fixation, there's been a lot of discussion about that. Most of us are familiar with the anterior, the ACDF and ACCF techniques. So for most neurosurgeons, orthopedic surgeons, it's a familiar technique. There's much less muscle injury, there's much less blood loss. And I think, generally speaking, most of us are quite happy with that. But in some cases where the anterior reduction fails, and in my personal experience, this has been the case with neglected facet dislocations. We do see quite a lot of neglected dislocations, which have been missed for several weeks, and then they arrive. In those cases, frequently posterior reduction is the easier way of doing things. And if you reduce posteriorly, do you then reduce posteriorly, fuse posteriorly alone, or do you reduce posteriorly, turn the patient over and do anterior fixation? I think I'm quite happy in those instances to do a posterior fixation, but in select cases, turn the patient over and do an anterior fixation as well. So this remains one of the controversies. So thank you very much. I hope I finished in time, but those were the few comments I wanted to make. Thank you.
Thank you, Professor Omar, for your excellent presentation. Thank you, Professor Rubiano. He's sharing some very useful documents you can see on the chat. We proceed with Professor Jyoti Parthiban, speaking about intensive care of spinal cord injured. Professor Parthiban.
Yeah, I will share my.
Professor Omar, can you unshare your screen, please?
I'm here. I'm trying to share my. You able to see my?
Yes, we can, Professor.
See my, okay. Yeah, I'm not able to enlarge it to the full. Can I go ahead with this like this?
Yes, maybe you can put play.
Yeah, I'm okay. Is that okay?
Yes, perfect.
Thank you very much. Thank you for the invitation. Pleasure to join all of you. And I'm from India, and it's a excellent topic to have a discussion with very nice faculties here. Acute spinal cord injury and the ICU management. It's very interesting to go through that. And most of the spinal cord injuries are very much cared only in the intensive care unit. So if you look at this intensive care of spinal cord injury patients are very diverse in the worldwide due to global inequalities in economy, infrastructures, and availability of specialists. This is most important because when you look at the various managements from different countries, it varies from one country to another country. And so we have to see as a total, and I found a very nice article done by the anesthesiology groups who are taking care in the critical care management in the United Kingdom. The management of acute spinal cord injury in non-specialist intensive care units, a narrative review. So this was a very excellent paper, and this summarizes, this is the flow chart of the talk, which I will go through, and try to make it as smart, as short as possible. The most important thing is the airway management with the tracheal intubation, which is very important for all the spinal cord injury patients, particularly when it is associated with a brain injury. And when there is a respiratory failure, which is about to be seen or you expect it so, then you need tracheal intubation, high cervical spinal cord injury, and also to facilitate a surgical intervention in acute period. So the tracheal intubation is very important and it has to be done as early as possible. The next thing is that about the intubation technique, which is very important, and we have to see that the cervical spine is not dislocated further and cause more impairment to the spinal cord injury. So the technique is depending on the experience base from the clinician and also assessed by for each case individually. This is a very important thing, tracheal intubation, and it's separate part altogether, but we should know as neurosurgeons, we should know about it. Subsequent to intubation is the tracheostomy. Tracheostomy is very important, particularly in very high grade complete quadriplegia like Asia grade A and Asia grade B cases which needs tracheostomy because they are going to be in the critical care for a very long time. Injury at C5 and above. Obviously, the Center for Innovation, which a phrenic now takes, is about the C4. So we all know about that patient will have respiratory failure. Increase injury severity, as I told earlier, and also when it is associated with the brain injury, with a Glasgow Coma scale of 8 or below. When there is a thoracic injury associated, which is very commonly we see in a combination of head trauma, cervical trauma, and thoracic injury. So all these things which needs more care, finally, we have to treat these patients with a tracheostomy. Then it comes to about the ventilation strategies. Mechanical assist devices are very important with aggressive physiotherapy. The physiotherapy started from the time of the admission of the patient inside the critical care unit with high tidal volumes of 15 to 20 ml per kg and zero positive N expiratory pressure. PEEP is very important, that need to be adjusted as needed. And whenever the strategy is made for ventilation, then there's a plan for weaning also. So this is very important. It is very difficult. And neurocritical care specialists, they have a lot of protocols for weaning process. Apart from the ventilation, we come to the blood pressure because blood pressure is very important, associated with hypotension. So the target mean arterial pressure must be approximately about 85 millimeter of mercury, MAP, for 5 to 7 days continuously to prevent hypoperfusion at injury site and prevent secondary injuries. Euvolemia and vasopressors, particularly about noradrenaline, is very essential, and that need to be titrated very well. There are so many things which at the research level is individualized perfusion and microdialysis, but they are not in practice at present in many places. Maybe in research centers, they are being practiced and maybe research is being done on that. But most of the thing is done with euvolemia and vasopressors. The weaning of the ventilator, after that is depending on so many factors. The weaning fails when it is defined as either the failure of spontaneous breathing trials or the need for re-intubation within 48 hours following extubation if you do it very wrongly. So a simple weaning is completely different from difficult weaning and prolonged weaning. So these are the aspects which we have to take in care while we treat the spinal cord injury patients. Weaning out also takes the part of the respiratory weaning strategy. And the strategy must be start in supine position and then in the sitting with abdominal binder, which is very essential, with the secretion clearance. So if you look at that, it's a combination of not only the clinical practice, but also with the nursing care with the secretion clearance. And the weaning out should be aimed at vital capacity of 5.8 ml per kg, spirometry. ABG should be routinely taken up. Patient should be afebrile, should not have any atelectasis. There should be a clear lung field and clear secretion management strategy. All these things are very necessary for weaning out of these patients from ventilation while the patient is being treated for spinal cord injury. And also the cuff deflation of the tracheostomy is a big challenge to many of the clinicians. So it is a very important thing to think about. That apart from that, the one point which we see is about autonomic dysreflexia, though it is not very acute, but they do see in 5% of the cases in acute stage. Usually they may be associated with CVS, with myocardial infarct, atrial fibrillation, premature ventricular complexes, and AV conduction failures. As far as CNS is concerned, they may have an CVA, headache, seizure, encephalopathy, sudden anxiety and apprehension, visual retinal detachments, blurred visions, and pulmonary edema. So it is a very, very uncomfortable situation which needs a sit-up and loosening of the clots, investigate and treat the precipitants. If the bladder is distended, you need to flush out the bladder, lidocaine catheter, avoid rapid emptying, and check the testicular torsion in case if it is there, fecal impaction, manual check, laxatives, evacuation, and check fissures. And pain is also an important subject, which I'll come to later, with pressure soles also carry a lot for autonomic dysreflexia, which need to be taken care. During this time, that ACS score has to be analyzed every period of time to assess the patient is improving or not. So this has to be standardized all over the ICU management. To come to the pharmacology, where the pharmacology is absolutely not being, be taken out of spinal cord injury, it's a big controversy because it is being going through since 1960. Methylprednisolone was being advocated in an earlier period, and then NACIS-3 came out with intravenous MPSS, about 30 milligram per kilogram body weight in the first 15 minutes, followed by 45 minutes of pause, and then 5.4 milligram kilogram of body weight for the next 23 hours. So this is the concept which came in the recent Green Book. And this Greenberg's book has mentioned very interesting point. I would like to come to that a little bit later about methylprednisolone. So the world is divided whether to use methylprednisolone or not. As in this article, you can see this article has seen the results up to 26 weeks, and they found that they did not have any demonstrate any enhancement in the neurological recovery. So it is being found that it is not very useful. And this is a Korean journal article which came very recently, tried to say that no, we should not use MPSS and we should encourage others to stop it. So there are so many papers which are coming like this, articles. But however, we have Michael. Michael is going to talk to next. And they did the very elaborate study. In 2017, they come forward with a very beautiful, this one, you can see that here, when the take case comes about, they offer to adults, if they come between less than 8 hours of injury, and you can give a 24 hours infusion as an option. So this was given by Michael's group. And subsequently, we came from WFNS Spine Committee, and we came with the consensus that selected young patients with no comorbidity should be given the opportunity with methylprednisolone. So the world is divided in so many ways. And another paper which came recently by Vincent Chong, and they said that we are not only seeing about a grade 0 quadriplegia, that is a complete spinal cord injury. We also have to think about the incomplete spinal cord injury patients, whether MPSS is useful in those conditions. That is another one. And finally, there's a very big paper on this. They analyzed the guidelines, which included our paper, our work in WFNS Spine Committee, and also Michael's article is also here. And they came with the conclusion. They were inconsistent. There were inconsistency in the recommendations of methylprednisolone. The evidence-based recommendations tended to recommend against using MPSs, whereas when you do have a consensus-based recommendation, they tend to recommend for. So that is what the reason Greenberg book has written, saying that 56% of their questionnaires consultants have agreed to use MPSs. So it is divided. Now, just a case example here. Here is a patient who came in the recently with the spinal cord injury. Here you can see came with incomplete, looks like incomplete with upper limb 1/5, lower limb by 3/5. And this patient was given with MPSs as per NASS 3, the dosage. And then for some reasons that they had to be taken the surgery after 4 days. And this patient is extremely doing well. Now,
Good.
now we do not know where exactly to put this patient in line.
How are you?
Whether this the
Sit down.
decompression
Please
has
take
done the
this
work, or the methylprednisolone has done the work,
Moment.
or it is the incomplete
How do you
injury
feel?
has done the work.
இருக்கீங்களா?
But
You joined the
finally,
army?
as human beings, we have to think about it
Join
that we have to
பண்ணீங்க.
give
Where
the
are you now?
benefit
Jammu Kashmir.
to the patients, whoever is fit, whoever is eligible, that without any comorbidity. So that is very important in concepts of one cannot have a blanket say no to MPSs. MPSs can be given in select cases when the patients are very young, when there is no comorbidity and no other injuries, isolated spinal cord injury. They do very well. Here you can see in the post-op MRI, you can see the healing has happened very nicely, decompression, spinal cord very beautiful, and there is a small vacuole that shows that the patient had a contusion here. It's not just a concussion that he came back. So there was a spinal cord injury there, but maybe it was incomplete at that point of time. The other point which I would like to emphasize is the venous thromboembolism, which is seen at least 8% of the patients in spinal cord injury in ICU. The low molecular heparin has to be started within 48 hours, and it is recommended very strongly to continue for 8 to 12 weeks, that is 2 to 3 months. Pain is very, very disturbing for the patient, both acute and chronic. So the musculoskeletal, it is due to the coexisting injuries, immobility and instability of the spine can cause severe pain. So one need to have a multimodal approach for that. Surgery, if needed, as our previous speaker said, that surgery needed, it has to be done. Peripheral nerve block, paracetamols, NSAIDs, and titrated opiates can be given. The visceral pain also maybe have to be seen very carefully because of urinary tract infection, constipation. This has to be taken care in the ICU. The neuropathy pain, which is about in 56% of the patients. This can be at the level of injury or below the injury. Amitriptyline, pregabalin, gabapentin, and duloxetine, they are some of the medications along with anti-anxiolytics and antidepressants are very useful in reducing the pain because it is very, very discomfort when a patient has a pain with the neurological deficit. This also should be taken care in the critical care patient in the ICU. Pain specialists will be of very great helpful in these patients. Finally, we have the rehabilitation, which needs the management of spasticity, the patient psychology, the mood, communication with the patients and relatives, readiness for discharge to rehabilitation, and then we need to prognosticate the patient. I thank you for listening to my talk. Finally, I would like to say one point. ICU is the important place that apart from our surgical, our skill, but ICU is the one place where it is going to change the patient's complete outcome. Thank you very much. Thank you.
Thank you. Thank you very much, Professor Parthiban, for your excellent presentation. So we continue with Professor Michael Fellings speaking on early versus late surgery. Professor? Unmute your microphone, Professor, please.
You need to do this.
Oh, there we go. And I submitted a video. So are we able to play the video? Will that work?
Yes. Abuja, can you please make it? Abuja, are you there?
Yes, I'm here. I'm trying to share.
Will you please make the video of Dr. Felix?
Okay. I will share.
Hello, Dr. Michael.
The voice is not coming.
Okay, I'm checking again.
If it's an issue with technical reasons for the video, I could present if that works. Or I can do that as well. Okay. Hello, I'm Michael Failings from the University of Toronto, and it's a pleasure to take part in this WFNS webinar. I'll be speaking on the concept of timeless spine and making the case for early surgical intervention in acute spinal cord injury. I don't have any relevant commercial disclosures. I have founded a regenerative medicine spin-off from my lab called Intelligex, but I won't be discussing any of that technology today. And I also wish to acknowledge a number of sources of funding support, which are listed on this slide. I wish to thank Mehmet Zaleli for his wonderful leadership in putting together these WFNS educational symposia. And I also wish to acknowledge the esteemed speakers that are taking part in this symposium as well. So I'll be discussing the rationale and the evidence for early surgical intervention for spinal cord injury. I'll discuss the current AO Spine guidelines, and then I'll present novel data on the role and timing of surgical intervention for acute spinal cord injury. And this will give a snapshot preview of the new AO Spine Praxis guidelines, which have just recently been published in the Global Spine Journal in 2024. And then I'll also discuss the evidence for central cord injury and Asia A spinal cord injury, because these are sometimes controversial topics that come up, and I'll make some conclusions and take-home messages. So when one considers the pathophysiology of spinal cord injury with a primary mechanical injury that is amplified through the processes of secondary injury, it makes sense to consider the potential role for a surgical intervention. And the idea here is to try to attenuate the impact of secondary injury mechanisms, including ischemia, inflammation, release of free radicals, and so on. And the basic concepts here in this patient who has a bilateral facet dislocation of the cervical spine with open reduction, internal fixation, and decompression of the spinal canal. And this is supported by a wealth of preclinical data, beautifully summarized by this elegant meta-analysis by Peter Batchelor. And in essence, these animal studies show that there's about a 35% improvement in neurobehavioral outcomes with early surgical intervention. And remarkably, this is actually roughly paralleled by the effects that we see in the clinic. So the STASCUS study was really the first high-quality prospective study to give a sense that there was an important positive effect by early surgical intervention for acute traumatic spinal cord injury. This is now published over a decade ago. And just by refresher, this was a prospective a study done in 6 centers in North America through the Spine Trauma Study Group. Over 300 patients were enrolled with cervical spinal cord injury. And in a nutshell, in patients who had surgery within 24 hours, and this was at a median time of 14 hours after a surgery, we saw that the odds ratio of patients having a 2 or more grade change in their ASIA impairment scale with early surgical intervention was almost 3-fold higher. This was a very large treatment effect, and this had a significant impact on standards of care around the world. This and a number of other studies evolved, and for the first time, we were able to issue recommendations that surgery was the preferred option for acute spinal cord injury, and that this was best done within a 24-hour time frame. Because of the paucity of studies, however, and the variability in terms of how outcomes were assessed, it was not possible to do a quantitative meta-analysis, and hence the recommendations were somewhat tempered. This really prompted us to do the following study that was subsequently published in Lancet Neurology. And this was an individual patient meta-analysis from a number of prospective studies. This included over 1,500 patients with acute traumatic spinal cord injury. And these are 2 of the key figures from this paper. On the left, we are plotting the changes in the motor scores as a function of time. The red dotted line represents 24 hours, and one can see that there's a clear dose-response relationship between a neurologic benefit and the timing of surgery. And in this histogram, we've plotted the changes in motor scores, again, as a function of time, and we see that the peak benefits are observed within 24 hours. This, in a number of other studies that were published subsequent to the 2017 guidelines, prompted us to issue a new set of guidelines that were just published in the March edition of the Global Spine Journal. And to date, this is the most comprehensive updated review on the timing of surgery for a spinal cord injury. And we use the GREAT approach for evidence synthesis. So this is one of the meta-analyses that was done. And this is the forest plot showing the recovery of 2 or more grades of function on the ASIA impairment scale at an earlier time point at 6 months and in a longer term a time point. And we again see on this logarithmic plot results that are reflective of the original STASCUS results. So about a 2 to 3-fold higher odds ratio of getting a 2 or more grade change in the ASIA impairment scale with early surgical intervention. We also were able to quantify the motor scores using the ASIA standards, and we see here that there was about a 4.5 motor improvement with early surgical intervention. And if this is potentially translated in terms of hand and upper extremity function in a quadriplegic individual, this can have a pretty significant effect in terms of their quality of life. Importantly as well, early surgery is safe. Complication rates are not increased, and if anything, there is a reduction as illustrated here in this forest plot showing mortality rates, which does not meet the level of significance, but it's very close to trending toward a reduction in mortality rates with early surgical intervention, strongly suggestive of the safety of this intervention and the fact that certainly complication rates are not increasing. If anything, there are trends toward reduction in complications. So based on this evidence, there is now a strong recommendation that surgical decompression for acute traumatic spinal cord injury should be completed within 24 hours after injury when medically feasible. And this is important because there clearly is a lot of judgment that is required. So for example, some patients are medically frail, some patients have multi-system trauma, and here one may not be able to intervene within the 24-hour time frame. And these guidelines allow the medical teams the leeway to exercise judgment in these cases. Now, what about the ultra early time point? And here we've defined this as within 12 hours for acute spinal cord injury. So it makes biological sense. There is some emerging literature support as suggested by this article from the UCSF group. And certainly if we look again at our article from the Lancet Neurology, we see this dose-response relationship suggesting that potentially earlier time points of intervention, when feasible, might be associated with benefit. Now, importantly, right around the time where our guidelines were issued, this paper, the SkyPome study from the European group, was published. And this was a study examining ultra early surgery versus more delayed interventions. And these authors compared an ultra early time point of less than 12 hours versus a combination of early and delayed surgery. And one of the challenges that these authors ran into was that because of the shifts in standards of care and care pathways, most of the patients in the delayed group actually had early surgical intervention. And so the differentiation between
Dear Michael, actually, we could not solve that blurring vision. It may be better that you continue from your own slides. Is it possible?
Yes. Can you enable me to have screen sharing, please?
Yeah, I will. Now you can.
Okay. Yeah. Thank you.
I thank you, really. Sorry for that. I don't know the reason.
Are you able to see my screen?
Yeah, yes. Yes, it's okay.
Perfect. And you can hear me okay? Video is all right?
Yes, Professor.
Thank you.
Yes,
okay.
yes, Michael.
So I'll go over
Please.
these slides quickly and then I'll kind of resume, but I realize that people may not have seen this, and apologies for the challenges. But you know, I've been asked to kind of present the current arguments related to the role of surgery and the timing of surgical intervention. I have no relevant disclosures, and again, to thank Mehmet and to acknowledge the esteemed team of colleagues. So I'll be talking about the rationale and evidence for early surgery, and I'll be focusing kind of on the evidence underlying the current AF spine guidelines. And then I'll talk about some of the controversies in knowledge gaps, and then also present some of the evidence around spinal cord injury and some take-home messages. So, you know, the concept of early surgical intervention is really based on the idea that the primary mechanical injury is amplified through the processes of secondary injury, and the compression of the cord and the ongoing instability in the spinal column enhances secondary injury. And so the the idea, which is really based on sound science, is that early surgical intervention would be beneficial. I think one of the challenges has been the implementation of this, but with the advances that have occurred in surgical technique, anesthetic management, ICU management, and so on, we've now seen that, that this is a reality that we can try to implement. And this is supported by strong basic science evidence, as shown by this elegant systematic review and meta-analysis by Peter Batchelor, showing around a 35% improvement in effect size in animal models, ranging from small animals to primates, with early surgical intervention. And interestingly, this is largely reflected in the improvements seen with surgical intervention. So again, by review, the STASCUS study, 313 prospective patients in North America through the Spine Trauma Study Group. And in a nutshell, we found that patients undergoing surgery at a mean time of about 14 hours after injury, but within 24 hours, had a almost threefold odds ratio increase of having a 2 or more grade change in the age impairment scale after spinal cord injury. So this study had a big effect worldwide on kind of standards of care and care pathways. And then based on this, the first set of guidelines emerged in 2017, suggesting for the first time that early surgery for acute traumatic spinal cord injury is the preferred option. Now, the level of evidence here was lower than we would have liked. This is the stringency of the grade guidelines, largely because there weren't a lot of other studies that we could combine with STASCUS, and so we were limited in terms of the quantitative meta-analysis that can be undertaken. So as a result of this, we were kind of inspired to undertake this large study, prospective study published in the Lancet Neurology, over 1,500 patients with all severities of traumatic spinal cord injury. And in a nutshell, we found quite compelling evidence in favor of early surgical intervention for acute traumatic spinal cord injury. So on the left is a graph highlighting the changes in the motor score as a function of time, a very clear dose-response relationship. And we see this red dotted line as the first 24 hours. So we see quite a marked effect within the first 24 hours. And this histogram has plotted the changes in the age of motor scores as a function of time after surgery. And again, the best outcomes cluster within this first 24-hour time period. So based on this, and a total of 21 studies that we were able to include, we were able to use a great approach for evidence synthesis and to formulate new clinical practice guidelines. And these have just come out in the Global Spine journal. And as shown here in this meta-analysis, we see quite significant, statistically and clinically significant improvements in outcome at 6 months and at 12 months. And we see improvements in motor scores, as well as a major increased likelihood of a 2 or more grade change in the age impairment scale with early surgery, essentially validating the results of the STASCUS study. And this shows the changes in the motor score. So on average, around 4.5 changes, motor point changes. And again, with a patient who's tetraplegic with a cervical injury, this would be quite an important effect. And again, the surgery is safe. Mortality, if anything, has a trend to a reduction. And so we now have a strong clinical practice guideline. Surgical decompression for acute traumatic spinal cord injury should be completed within 24 hours. Now, when it's medically feasible, and this allows the medical teams leeway to exercise judgment in patients that are medically frail, older, medical comorbidities, the setting of polytrauma, and so on. And it's also recognized that there's substantial logistical challenges, sometimes with the transport of patients to get there in the first 24 hours. And this kind of brings forward the challenges in the implementation of these guidelines. Now, what about ultra-early surgery, which we've defined as less than 12 hours after acute spinal cord injury? And it makes biologic sense. There's nothing inherently magic about the first 24 hours as a cutoff. It's that this is logistically feasible. It allows teams to stabilize the patients. And this is one study from UCSF's providing data to suggest enhanced recovery with ultra-early surgery. And this is also reflected again in our Lancet Neurology article, where again, this dose-response relationship between the timing of surgery and optimal outcomes, with the optimal period being within this 24-hour period. Now, this is a SkyPoem study that was published just as we are completing the guidelines development process, and we do make reference to this article in our global spine journal. And essentially, this was a study done in Europe where they were examining ultra-early surgery within 12 hours versus later surgery. And one of the logistical challenges that these authors ran into was that there was a shift in essentially standards of care in Europe. And most patients in the delayed group actually had surgery within 24 hours. So the difference between this ultra-early group and the delayed group was actually quite narrow. Having said that, the unadjusted analysis did point in the direction of enhanced lower extremity motor scores with ultra-early surgery, but there's some technical challenges. There were some baseline differences between the two groups, which were challenging to balance, and there was some loss to follow-up. So I would say that this study right now is inconclusive, but it does point in the direction of a potential signal for ultra-early surgery. So it makes biological sense, but further evidence is going to need to be required. And now, importantly as well, what about patients, let's say, with a cervical ASIA A injury? And about 44% of these patients will shift their ASIA motor scores and ASIA grades with early surgery. But what about when they don't? Is early surgery still worthwhile? And this is a very nice article from Valerie Terwengel in the Netherlands that we are part of. And essentially, Valerie showed an early surgical intervention in patients with a motor complete cervical injury is associated with a gain of 2 or more motor levels. So for example, let's say like a C5 patient going to a C7 level. That's a big effect in a tetraplegic individual. And then what about central cord injury? I present this case of a patient with ossification of the posterior longitudinal ligament. And the nature of my practice in Toronto is that it's an extremely multicultural center, and we actually have a high Asian population. We see quite a bit of OPLL and central cord injury. And this is actually becoming the commonest form of spinal cord injury that is being seen in high-income countries as well. This issue is becoming more important. The global burden of traumatic brain and spinal cord injury remains high, and we're seeing a shifting demographic where we're seeing older patients, more fall mechanisms, and more cervical injuries. So this was a propensity-based prospective study, which we published in JAMA Surgery about a year and a half ago. 186 patients with central cord injury, 93 early within 24 hours, 93 delayed surgical intervention after 24 hours. And the overall results did show a favorable benefit of early surgical intervention with improved motor scores. But when you drill down and you look at, let's say, more severe injuries, ASIA C, versus milder injuries, ASIA D, the predominant benefits are seen in the ASIA C more severe injuries. Now, could there be a benefit in the ASIA D population? There could be, but we need to have more sensitive outcome measures to detect this. And so the conclusion from this paper was that early surgical decompression for severe ASIA C central cord injury was associated with neurologic benefit, and we need further data, I think, to make judgments on the ASIA D patients. And the technique of surgery matters. Surgery has there's a significant art to doing this. Bijan Arabi's work points to the fact that the quality of the decompression is probably just as important as the timing of intervention. And there's new techniques that are evolving, so the potential use of expansile duroplasty is under investigation currently in the UK by Papadopoulos' group. So take-home messages in future directions. Surgical decompression for cervical and thoracic spinal cord injury within 24 hours of acute spinal cord injury improves neurological recovery. And the 2024 AO Spine Praxis Guidelines, which have now been published in the open access in the Global Spine Journal, does make a strong recommendation for surgery as soon as possible within 24 hours, regardless of level of injury. Now, having said that, there is leeway of course, to exercise medical judgment, and for the reasons I've indicated, medically frail patients, patients with polytrauma, sometimes when there are delays in the transfer of patients, and so on. There's nothing magic about the 24-hour cutoff, and time is fine. The timing matters. So in a young person without medical comorbidities, I think that ultra-early surgery makes sense, especially for an incomplete cervical injury. But as always, there's a lot of judgment that's required. So on that note, happy to close. Sorry about the technical issues with regard to the video, but fortunately, I was able to present this live as well.
Thank
Great
you.
talk, really. We enjoyed it a lot. And now, Sergio, you can moderate the questions, discussion.
Yes, yes, Professor Zeliali. Any questions? No hands raised. I think the 4 presentations were very rich.
There was a couple of questions.
Sergio,
Yes, yes, Professor.
I'd like to.
Oh, sorry. Go ahead, Juddy. I was just going to comment on questions in the chat, but please go ahead.
Yeah, I think we go with the same line that this ultra early surgery is very interesting. When we were thinking about the first 4 hours of the injury before they go in for the secondary injuries to take place, if you look at all the research, also says that everything done very early actually improves the patient, particularly in incomplete injuries. So my feeling also same. The last point which you made, Michael made, was absolutely very important because many times the incomplete injuries, showed one patient also, you can see that incomplete injuries, they are more likely to improve very well with early surgery. But only thing is that when the patient comes to us, we do not know, depending on the place where we practice, the type of the places where the facilities are available to, or the patient is very close by to your hospital, who reaches very early within 4 hours, 2 hours time, and provided they are isolated spinal cord injury. So it's very interesting point because I also compare the same thing with the infusion of methylprednisolone within that short period of time, 4 hours. There is always a point of discussion for incomplete spinal cord injury. I think, Michael, I would like to really want some of you can throw some light on that when comparing this ultra time surgery and also the application of MPSS in a very short time, that is within 4 hours. So that point seems to be very interesting. Both surgical decompression and at the same time, the effect of methylprednisolone, which we found very useful in the laboratory.
Okay, thank you. So maybe I'll address the 2 concepts separately, but they're kind of linked in a sense. So I think the first point for all of us to recognize, and I think which we realize, is that the rate determining effect of the impact of a spinal cord injury is the primary mechanical damage. The worse the damage, the worse the primary mechanical damage, the less likely that there will be improvement either spontaneously or with surgical intervention. And the reason that the outcomes are better with an incomplete let's say spinal cord injury is that you have an underlying substrate that will facilitate greater recovery. Having said that, even when patients, let's say, don't change their Asia grade, you have the opportunity to recover motor levels. And I think that's an important take-home message, from this. What is the impact on the secondary injury? Well, the secondary injury contributes perhaps 10 to 20% to the ultimate pathophysiology. It's what we can target. But realistically, let's say if we look at surgical intervention, or if we look at, let's say, drugs to attenuate inflammation like with methylprednisolone, The effects will vary depending on the type of injury, but overall, we're still going to be looking at effects that perhaps can be viewed as somewhat modest. So the effect of surgical intervention, based on our Lancet article and based on the systematic reviews, is around 4 to 5 motor points. This, interestingly, is also similar to the effect seen with methylprednisolone, just FYI. And the original thoughts were, oh, these effects are so small, they don't matter. But that's not necessarily true because it depends on the patient, et cetera. So let's say a cervical patient, 4 to 5 motor points could be a pretty big deal because it could result in enhanced hand and upper extremity function, for example. So I would say that, and the other point I'll just make with methylprednisolone is the concerns that were raised, let's say around the safety of the drug, are probably no longer valid. This is we're in the 21st century. Our ability to manage medical complications now is so much better than it was 20, 30 years ago. And we have a paper actually that we'll be presenting at the upcoming ISCOS meeting in September showing that the complication rates actually with corticosteroids are actually reduced. And, again, suggesting potential beneficial effects, but in subsets of these patients. I think kind of one of the biggest challenges that all of us face, and probably many people on this webinar, relates to the systems of care. And it's probably quite difficult often to get patients to your centers within the first 24 hours. And I think, so a couple of points here. One is, I think that we have an opportunity to look at the systems of care and what can we do to enhance systems of care, and not just in high-income countries, but also in low and middle-income countries. That's one point. The second point is that let's say that a patient does arrive at your center 2 or 3 days after the injury in a more delayed fashion. It's still better to operate than to not operate, okay? Because, although maybe it's not optimal, it's still better because you can get the patient mobilized faster. There still is a potential opportunity to get some recovery of function. I'm often asked that question. So maybe I'll just pause there, but I think Professor Parthiban's brought up, some very important points for discussion.
Thank you, professors. Any more questions, contributions?
There are some questions in the chat, Salvador.
Let me check our chat.
There was a point that was raised by Dr. Caceres. I hope I pronounced your name correctly, which I answered in the chat. But this is just around, there's still groups not convinced of the benefits of early intervention in terms of disability. Look, I acknowledge the fact that there's groups around the world that still don't necessarily buy into even the role of surgery. I was just speaking with a group that were wondering, why are we even operating on patients? And, I think that the landscape has changed. We have much better assessments of stability, and stability surgical techniques have improved. And in terms of the role and timing, I think that, again, if you can get enhanced neurologic recovery, there is very good evidence that it's going to improve quality of life and function. So you can, for example, look at the impact of enhanced motor recovery in the upper extremity on the spinal cord independence measure, the SCIM, and patients have more function. And if you look at the SF-36, health-related quality of life, they rate their quality of life as better. So that's pretty important, I think. And one of the things I have learned from patients is that small effects matter. And I remember we had a patient that was involved in our discussions in the 2017 guidelines, and we were debating the effect of methylprednisolone around, okay, what is the minimal clinically important difference? And what this person said to us, he said, if I can move my finger, I can operate an electrical appliance, a smartphone, and I can have much greater independence. And that was quite impactful for all of us. And so I think realistically, small effects matter. But what I would say is that all of these guidelines are guidelines, and the importance of these webinars. And I want to again thank Dr. Zalali and the leadership here of the WFNS, Dr. Rubiano and others, for putting this together, because it's one thing for Dr. Failings and team to write these nice guidelines and these articles and stuff, but how do we implement this, right? How do we actually practically do this? And this still requires tremendous judgment on the part of the surgeons, right? And these are just guidelines. They're there to guide your management, right? And I think as we move forward collectively, we need to think about, okay, how do we raise the bar to enhance this? And at a personal level, I think this is why I feel the WFNS is so important in terms of kind of moving this forward, at the international level. And again, I really want to convey my appreciation, very, very deep appreciation for the leadership of the WFNS for putting webinars like this together and for showing leadership here.
Thank you, Professor. We have a question here from Dr. Pascal from Egypt about early decompression. You mean decompressive laminectomy alone or add dura augmentation?
Yeah, so this gets to the technique of decompression. So again, basic surgical principles arise. So a closed reduction of a fracture dislocation is a technique to achieve decompression. We do recognize that the cord swells after injury. And so I think it's, let's say, in the setting of a bilateral facet dislocation, if you can get the facets reduced, then I think adding a stabilization and then a decompression would be quite helpful. And I think doing a laminectomy with a stabilization, intraoperative ultrasound, which I think is more and more available, is a nice intraoperative technique to assess the quality of the decompression. But if there's a disc herniation anteriorly, an ACDF, that may be sufficient. But I think it depends on where the decompression, on where the compressive pathology lies.
Thank you, Professor. Professor Rubiano, you raise your hand.
Yeah, thank you. I think this discussion is really important and critical. We have been going over every one of the steps for the management of the patient. We have facts now that pre-hospital care is not widely available in many regions of the world. We have facts now that there are so many heterogeneity regarding the emergency care of these patients. And we have facts now that as early as possible, the surgery is beneficial from the patient. I just want to give or have this question for Professor Failings, Parthiban, and also for Professor Uma, in order to have the different perspectives, because when we have the first iteration for the bootstrap spine, we have this specific question that is very critical and is recorded of the context. In many regions of the world, you have the possibility to have early imaging of these patients, not all the time and not free sometimes. Some families need to pay for it, but you have the first view of the patient that needs or can beneficiate for early surgery. But what happens is in many regions of the world, the hardware and the system for immobilization is not available in the first, 48 hours or something like that. So the critical question is, if you have a patient that have indication for decompression, but you don't have how to stabilize that, what is your perspective of what to do in this specific case? So I want to have the question for the three of you.
I'd like to defer to my colleagues. I think I've spoken quite a bit. I'd like to be very interested in the perspectives of my colleagues, and then perhaps I can add a few comments as well.
Professor Uma?
Thank you. That's an interesting question. So from a global perspective or a third world perspective, I think it is it's a situation we commonly find ourselves in, so a patient arrives at your primary or secondary hospital, and, where we work, imaging, at least basic imaging, is not a problem. Basic, by that I mean, for instance, getting a lateral shoot through X-ray, etc., may not be a problem in the primary or secondary hospitals. And so one can make a determination that here is a patient where there has been a dislocation, where something is necessary. The problem then comes from that point, transferring the patient to the central hospitals where, further surgery can be done, proper decompressions and fusions can be done. The truth is, there is a serious problem in a country like South Africa, which has got a two-tier system. The system where there is private care for the insured patients, that's not a problem. And so I wouldn't discuss that, because patients who are fortunate to fall in that category will not generally experience the problems which the 85% of patients who don't fall in that category will experience. The truth is, many of these patients will come off second best, because there will be delays in transporting them to hospitals where this decompression and surgery can be done. So for us that work in the central hospitals, we typically will receive the patient in a delayed fashion. And so you have a patient arriving 24, 48, 72 hours later with bifacet dislocation, Asia grade A, etc. And that's what you deal with. So when the patient does arrive, of course, you proceed and do your best in those circumstances, but you're cognizant of the fact that your results are not going to be anywhere as good as they would have been had you seen this patient immediately. So I think the short answer to that question is that as we deal with them as and when they arrive, and we do our best under the circumstances to achieve a decompression, to achieve a fusion, in select cases, a decompression, because once they have arrived at the tertiary center, they will then have all manner of investigations, and one will be able to see exactly to what extent we are dealing with cold swelling or, facet fractures or dislocations. And so the correct treatment can be rendered, but the fact of the delay cannot be erased. So I hope that sort of gives you some insight into what happens in the South African situation.
Thank you, Professor Uma. In Mozambique is the same way. We have the same challenges and the same kind of system. Professor Parthiban?
Yeah, now India is, it has very wide, in some parts we are very advanced. In some areas that we do even have air ambulance. There are in some areas where our patients' reachability is very fast. In some areas, it is very slow. You all know about the size of India, Indian continent, and it's all much different. At the same time, even the hospitals also different. Where I practice, I have all the facilities. For example, that I have MRI, CT, ultrasound, theaters, emergency care, all in one level. So when I speak it from my viewpoint, we will do the best of international standard at the time when the patient arrives. So we do not know how quick the patient comes to us. That's what I was talking about it. So sometimes we get the patient in 2 hours time. Sometimes we get the patient in 8 hours time. So it varies to different time zone for the patient to reach us. But the treatment wise, we follow the international standards. We try to operate the patient as early as possible. It's not only the time, but it's not like some of the developed countries where we have the government sponsor for the treatment. In India, the majority of the patients are they have to pay by themselves. So there are corporate issues. So one has to adjust with all those things. Treatment wise is the same. In fact, when I was talking to you, I was also discussing about methylprednisolone effects. And we are the one who use methylprednisolone in young patients, eligible patients, because as Michael was talking about it, the so-called complications have come down drastically in the past 15, 20 years because the care has gone up. So the standardized treatment is very, very adapted in my place where I work, but it may not be the same thing in a smaller sector. So it's very difficult for me to say what happens in a 3-tier city in India. Even in 3-tier city in India, there are neurosurgeons who are operating within 24 hours time. So we adopt to the standard of care whatever the developed countries are having. So within you mean that 24 hours time surgery, all investigations together in one single slot. That is your CT scan, your MRI, everything is done in one way. So it all depending on the places where the patient lands in. So I personally feel that we cannot have a strict the regime. It has to be done this way, but a standardization has to be made, and that standard, whenever is possible, has to be applied. That's my view.
Thank you, Professor Parthiban. And Professor Rubiano, what's your experience on that?
No, I just was
Reality.
mentioning this because in many places, and even sometimes in our center, we have patients, we have the team there, but the hardware is not available on time for the first 24 hours. So the question is, if you have the possibility of decompress the patient, but you don't have the possibility to fusion it, what will be the best approach? Because you are right to this position. So I am in the position of maybe these patients need to be offered to the early decompression, but it all depends on what is the postoperative care that you are going to have over that patient, because sometimes managing patients that does not have fusion is a very complicated case, and you can generate more complications in a patient that you operate with early decompression, but you don't have the fusion techniques possibility. So early also. So that's why I am asking here, because this point was very critical when we were doing the stratification for management of care, because this condition is very common in many regions of the world. So I want to hear Michael's approach related to that.
So,
Links.
Can I ask something?
Yeah.
Sergio? Yeah,
No,
actually,
I was
first
giving...
of all, I thank all the speakers. And they were really very nice talks. Dr. Andres Rubiano, Dr. John Uma, Juti Parthiban, and lastly, Michael Felix has given very nice messages. I find two take-home messages here. We must operate as soon as possible if we see a spinal cord injury patient. This is one message. The other one is the intensive care management must also be a part of our routine. Probably in many places, especially in limit countries, it is lacking. And we don't that much monitor the blood pressure levels. So we must then take on messages that intensive care is necessary and early surgery is necessary. Do you have any other comments? Thank you.
I think that's an excellent summary. Time is fine.
Not able to hear. You're not able to hear?
Let me try again. Are you able to hear now?
Yeah.
Yeah, I think that Mehmet's take-home messages are excellent. I think that what I would add to this is that time is spine, that we need to advocate for enhanced care pathways in all sectors of the world, and to look at practical ways to implement these principles, not just in high-income countries, but in low and middle-income countries as well. So I think that's one of our challenges. I think to Andres's point, I would be hesitant to do a decompression without a stabilization. I think the nursing care would be extremely difficult, because if you do the decompression, you have destabilized the spine and you potentially risk further injury. So I would discourage that. I think it would be better to wait until you have the materials in place. And I'm increasingly aware of some of the challenges that my dear colleagues around the world face, and it's my goal to try to create the arguments to enhance the infrastructure that you have to provide care for your patients. And my hope is that the evidence that we provide, let's say through the guidelines, would, I think, allow us to make those arguments. And then potentially, you know, through international bodies such as the WFNS, if we come up with consensus statements, you know, this will help. And then I think also, you know, trying to address these points. And Dr. Uma, you might be interested to know that I've been invited to South Africa in August to attend the neurosurgical conference there. So I will be speaking on some of these topics, and I look forward to interacting with yourself and other colleagues in South Africa.
Thank you. Looking forward to seeing you. Thank you.
Yes, there was a question from a participant telling that shall we do a laminectomy for decompression? It's not the answer. I think we must stabilize and make good realignment of the spine. This is decompression, actually. It's an old-fashioned thing, telling that laminectomy alone is enough. It's not that. Thank you. I think we can complete our session here. Sergio, do you want to add something else?
Yes, no, just to thank Professor Rubiano, Professor Parthiban, Professor Oma, and Professor Fellings for these excellent presentations. Very interesting discussion, nice topics. I think we still have a lot of issues that are controversial, but the important thing is to discuss and to clarify when to do the things on the best interest of our patients. That's it. And thank you for the opportunity of moderating this table to Professor Zeleli.
I thank also the participants.
And the participants, of course.
Yeah.
The most important
ones.
You. Thank you.
Thank you and goodbye.
Thank you.
Nice to see you.
Goodbye.
Bye.